Sri Krishna,
చెప్పండి సార్.
YouTube రికార్డ్ చేస్తున్నారా?
Yeah. Now we are live on YouTube. We'll start in the next 30 seconds. I'll just change the settings as well. Yeah, Dr. Mahati, welcome, ma'am.
Hello, Andy.
Mahati, could you just share your screen before we begin?
Hello, Satish garu. Good morning.
Hello, Andy. Good morning, Andy. Hello, Prasad garu. Everybody is there. Sri Krishna.
Dr. Satish, please share your screen before we begin.
Yeah, done, no?
మీది స్క్రీన్ షేర్ చేస్తారా ఇందాక ప్రెజెంటేషన్?
Yeah.
Okay.
Yeah, I am able to share screen. Do you want me to put the slide again?
Yeah, please do. Just so that there's no hitch after we begin. Dr. Mahati, please share your screen if you can.
Yeah, I will do that.
I think it's working fine.
Yes, I'll show you that in a second. Amma Krishna, is this okay?
Full screen వెళ్ళి ఒక 2 slides ముందుకు వెళ్ళండి సార్.
Okay, yes. Amma logo బాగుందా సార్ భాస్కర్ గారు?
బ్రహ్మాండంగా ఉంది. థ్యాంక్స్ అండి.
Parag, just let me know if you can speak.
Yeah. I'm okay. Actually, I just joined through the mobile, but I'll join with the computer within next 5 minutes.
Yeah.
Okay. Dr. Anshul, anyone else left to be made co-host? Because I'll mute everyone else when Dr. Prasad starts. Yeah, I think we're good.
Shall I
Dr.
stop
Mahati,
sharing? Amma Krishna, shall I stop?
stop. Yeah, sir. You can stop sharing.
Okay.
Dr. Mahati.
Hi, I'm just trying to share the screen, but it's not
Yes.
letting me unless.
Ma'am, you're a co-host, so you should be able to do it now.
Yeah.
Yes.
Just go to a full screen view and a couple of slides to run through.
Can you see it?
Full screen view. Like PowerPoint, presentation.
Oh, wait.
Yeah, play.
Yeah, that should be good.
Yes. Yeah, you can just go to just change the slide so we see if it's been changing.
Yes.
Yeah.
Great.
Ma'am, you can stop sharing. We're good to start.
Mahati, good evening.
Hi, good evening.
Welcome, Mahati garu.
Hello.
Yeah, muting all. The co-host can unmute and share screen at will. We'll begin now. Good morning, everyone, and welcome to today's IAP Twin Cities branch symposium. We welcome you all for a very exciting day ahead of us. And today's topic is on pediatric emergencies. And one of the very distressing moments for us is when we see a child in an emergency situation at any point of time. Could be in our clinics, in the hospitals, or even in the ICU setting. And handling pediatric emergencies is down to updating our own knowledge and also updating our skills. And today's session has very interesting topics. I think most of the time we feel critical care and emergencies, especially as pediatric practitioners, we find it may not be really our cup of tea. But today's topics are very unique. We have topics which relate to how to organize a ICU setup in a small and a medium-sized hospitals, and how do you manage pediatric shock, septic shock, status epilepticus, and a systematic approach to pediatric trauma from someone from the US, and a very interesting panel on how do we really manage these pediatric emergencies in the periphery? Which one do you refer? When do you not refer and use the time available with you? So I'm looking forward to very interesting sessions today. I now hand it over to Dr. Bhaskar, our president, to please give us remarks and then we begin. Over to Bhaskar, sir.
Yeah, thank you, Dr. Harris. Distinguished faculty, respected participants, Ladies and gentlemen, good morning to you all and good evening to Dr. Mahati. And I welcome you to this third IAP Twin Cities Branch Symposium on Pediatric Emergencies. I hope I'm sure it's going to be a wonderful program for various reasons. As Dr. RSV said just now, 2 decades ago, there was a lot of phobia about pediatric critical care, a lot of fears among the healthcare professionals, particularly pediatricians, to treat the critically ill children. But things are changing now. There are many intensivists in Hyderabad, all over the world probably, and there are many hospitals who are managing intensive care units so well with some training as a fellow or even otherwise working with the fellows, working with the premier institutes. So taking cue from this interest and enthusiasm among the members of our IAP, I'm very happy to say once again that we had started Telangana State Branch of Indian Academy of Pediatrics Intensive Care. So we have a Telangana State chapter, which has come to limelight thanks to Dr. Dinesh, who is the chairperson of 2023 for the national chapter, that is IAP Intensive Care chapter. And thanks to our senior member, and who is going to be the chairperson for this year, who is none other than Dr. VSV Prasad Garu. He is one of the few the senior most intensivists in Hyderabad, who has trained many intensivists in Hyderabad and other parts of Telangana state and neighboring states. So we call him as an intensivist for the intensivists. I hope around 30 to 40% of the intensivists practicing in Hyderabad are being trained by none other than our Dr. VSV Prasad. So he's presently the CEO of the Lotus Hospitals for Women and Children. Dr. Dinesh is the backbone of the new chapter, and as well he had brought in the revolutionary changes about the concept of pediatric intensive care since last 1.5 to 2 decades. As I told you before that, even I was running a small hospital. We were taking care of the critically ill children, but with the blessings of God, they used to become all right and they used to go. And some of them used to become very bad and we used to refer them. That time there were only few hospitals which were taking in, and Neelafar used to come at our rescue. Now the things have changed. And I'm really tempted to say a few words about our IAP Twin Cities branch. It has around 1,800 members from Hyderabad and Secunderabad. And we do, academically, it's a vibrant, dynamic body. For example, since January, we have been doing the symposia every month on first Sunday. This is the 4th one we are doing. We do IAP clinical meetings wherein we do present 4 very interesting cases from our hospitals in Telangana state and Hyderabad. That's 4 cases. And also we have IAP PG clinics. That's a pure clinical meeting oriented towards residents to train them in clinical evaluation of the child. We have a journal every month, and I'm sure with this new chapter at Telangana state, we are going to bring in a lot of changes in critical care activities, and many people are willing to join us to provide a better care for the sick children. And my special thanks to Dr. Mahati, whom I had requested a few weeks ago, and she had readily accepted. She did her residency in New York, and then she did her fellowship at Emory, Atlanta Emory. I'm sure all of you know, it's one of the renowned pediatric institutes in US, based at Atlanta, Georgia. And she had done a wonderful job during pandemic period of 18 to 24 months. She never ever used to visit her parents who are there in US. She used to spend most of her days and nights in US. Kudos to Mahati. You have done a wonderful job. You had taken our Indian nationals' values to a higher level. Thank you very much for joining us. And Actually, I thought of talking to you about Dr. Suchitra, but I'll talk when she joins us. But the only thing is, she's in nutshell, she's a jewel of this symposium. She's a jewel of this symposium. Other things I'll talk when she comes there. And Satish Ganta, thank you, Dr. Satish Ganta. Ever since I told him to be the coordinator, I'm sure every day he's spending 15 to 20 minutes how to do the program, how best he can do, how best he can coordinate with the panelists, and to how best he can do for IAPTC. Thank you, Satish. And our Anjulayal, always cheerful, looks always young, and he's young, a dynamic personality, and the treasurer of our new chapter, Telangana State. Thank you, Dr. Anjul. He's a lead consultant and head of the Department of Pediatrics at Continental Hospital, one of the very well-reputed hospitals in Hyderabad. We have with us Dr. Pritesh Nagar, again, a very great academician, a principal person, working in Care Hospital. That's another big corporate hospital in Hyderabad. Dr. Chetan Mohandada, again, a pediatric intensivist, doing a commendable job at Yashoda Hospital, Secunderabad. Yashoda is also another well-known. Dr. Parag Dikate, another young, energetic man who did his MD from PGI. Then he did his fellowship from Sick Kids, Toronto, Canada, and doing a great job, including ECMO at Kim's Cuddles. With these few introductions, I'm tempted to introduce you all because you're really the galaxy of the faculty. That's why I'm tempted to spend some time talking about you briefly. But my colleague Dr. Anjul will be talking when it comes to the presentations. Once again, I thank you all, and I sincerely thank our participants. There are already around 50 persons at 9 o'clock on Sunday morning. It shows their interest towards our critical care, pediatric intensive care. I'm sure at the end of the symposium, we all will have a great learning experience and great academic sharing experience. Thank you all once again. And Mahati is my classmate's daughter. They moved to US in 1991 or 90. She was a small kid when she left India, totally brought up in US. His parents, Rajendra is a pediatrician, one of the few best friends. When I say few, it's hardly 3 or 4. And mother was an obstetrician here, but after moving to US, she became an internist. So that is the lineage Mahati has. That's why I thought of introducing it. Thank you, Ananda. Thank you very much. Over to Dr. RSV.
Thank you, sir. Now I hand it over to Dr. Anjul to take over the proceedings.
Thank you, Shri Krishna, and I should thank on the onset Dr. Bhaskar sir, who's the president of IAPTCB, and his zeal to have this academics is beyond any doubt. And I think he didn't do justice to himself. I think he's one of the a key person instrumental in starting the pediatric critical care chapter in Telangana branch. And thank you, sir, for all your efforts. And we will always be happy to be associated with you. Now, to start the session, we have very exciting lectures, as Dr. Bhaskar has said. The first lecture is by none other by Dr. VSV Prasad sir, who's the chief pediatric intensivist and CEO of Lotus Hospital. He has over 31 years of experience. I think he is one of the first pediatric intensivists who started the roots of pediatric intensive care in Hyderabad. He is instrumental in starting the hospital, which is branded now as a tertiary level pediatric hospital. He has done his MD from AIMS and then has worked in one of the best centers across the globe in US and UK, and also have an FRCP from UK, and he's been bestowed with various national and international awards. I think as Dr. Bhaskar said, that he's one of the teachers who has trained, I think, most of the, at least 50% of the pediatric intensivists who are working, not just in Hyderabad, but I think all across. And today he will be giving his experience about how do we manage and open the PICUs in the medium level hospitals and the smaller centers, And I think there can be no other person best to talk about this topic. And I think he's going to do a great job over there. So I hand over to Dr. Prasad, sir.
Good morning. Firstly, Ugadi Subhakankshulu to everyone.
Thank
We
you.
just entered the Telugu New Year. Gudi Padva for all the Maharashtrians and everybody else. It's indeed a pleasure to participate in today's program. I can see the energy levels on a Sunday morning. It's just like a weekday for all of us. I'm really happy to be part of the program today. And the topic which has been allocated by Dr. Bhaskar sir, he was more keen on knowing how we can start intensive care units in a low resource setting. So let me share a few ideas and thoughts and also some experience along the way. The last 23 years or nearly 24 years I've been in Hyderabad. Thank you, Anjal, for the kind introduction. Thank you, sir, for the introduction. I will share my screen. So the organization of a small pediatric ICU in small and medium-sized hospitals. We know that emergencies in children are among the most time-dependent illnesses. In essence, if time passes beyond a certain phase, the child slips into a phase where it becomes even more difficult to resuscitate and improve the survival rates. There is a narrow margin of safety and for survival in children, and we have to recognize that, and that's why the golden hour and other things have come, the PATS guidelines. As we know, most emergencies happen without warning, and access to appropriate levels of healthcare is crucial. The first thing is recognition of the magnitude of the problem, how sick the child is, and somebody who is competent who can do a rapid assessment, and more importantly, instituting quick therapy. This data is from the Ministry of Health and Family Welfare, Government of India. You can see the NMR, the U5MR rate in 2016 was 39. It has dropped to 36. It's only marginal, but still the bulk of the deaths that we see in the periphery and in the country are still below 1 year. The bulk is neonatal and then infantile mortality rate. So there's a long way to go, and there are many, many things which we can do to improve survivals in the periphery, where access to healthcare, access to...
I think your slide could not be shared. I think just slides are not coming. Just share it. One. It's not coming as shared slide.
Dr. RSV, are you there?
Yeah, now I think, yeah, your slides are coming, sir. So you can just go to the first slide.
Sorry about that.
Yes.
This is the title slide. Just talking about the introduction and the data we have now of U5MR, that's under 5 mortality rate. It has only marginally reduced, and the bulk of the U5MR children that we lose on a day-to-day basis across the country are all mostly under 1 year. And among them, a significant fraction is neonatal. So to start a PICU in a district level hospital, I know the slide looks a bit crowded, but I'm just going to highlight the most important points. This specialty, if you need to run a good, effective PICU, requires a very high intensity, a high commitment specialty, which requires dedicated personnel, dedicated both in the medical, nursing, paramedical, and the complete level of support staff. It's not a one-day affair, it's for a long, long time to come. Most importantly is to have one leader, the in-charge intensivist or a director who has got sufficient qualification and training in not just general pediatrics, but intensive care. I know of many doctors and specialists who have been practicing intensive care. They do not have any certified training, but they're as good as someone who's already gotten certification. But somebody who has got leadership skills, who has got the confidence levels, who can train, has the skill sets, that's most important. And in this specialty, one cannot work alone. You have to work as a team. So you need to put together a good team, medical level staff, you need junior, mid-level PICU consultants, postgraduate qualification with some training, fellowship, and they should be available, at least 2 of them, so that for 8 hours a day minimum, plus off regular hours when there's a problem. More importantly is your nighttime staff, registrars. It can be DNB postgraduates, MD postgraduates in a government hospital, it doesn't matter. But once they're trained and they're capable to recognize serious illness and they know the PALS protocol and they're trained to do it effectively, they can cover the ICU at night time. Of course, a senior consultant or somebody who is capable should be available at short notice, and that's most important. You can only guide to a certain point on the phone, beyond which you'll need to be there physically to address the issue and sort out the patient. Equally important, I would say, is the nursing staff, where you need to have a good in-charge PICU nurse who's got minimum of 8 to 10 years experience, who has handled critically ill children with multiple problems. And she should also be a teacher, should have been able to put together a good team of other nursing staff who can look after the children. Very important again is support medical staff. We cannot do things alone because the spectrum of illnesses that afflict children who will end up in the PICU involves many, many other disciplines of medicine. For example, pediatric surgery, you need to have them at short notice. Orthopedics, neurosurgery, plastic surgery, etc., cardiology and all that. I know in the periphery, it's difficult to get hold of the specialists, but if you have access to them, they are willing to support your team at short notice, that should be good enough for the time being at least. Again, you need a lot of paramedical staff to support your unit, radiology, ultrasound technicians, you need a good biomedical engineer, and you need maintenance engineering people. Sometimes there's some water leakage somewhere, or drain gets blocked, or the AC stops working, or the UPS system completely conks out. So you have to have somebody who can take care of these things. This is as far as the clinical part of it. Then you need somebody with good administrative skills, an admin officer, typically as a doctor turned administrator who's good, and of course, billing, reception, many other things. Invariably, no PICU stands out alone. It's part of either a children's hospital or a multi-specialty hospital, a part of a big department. And that's the way most PICUs are set up. You cannot function in silo alone in a building because so many support staff, support specialties are required. The first thing I'd like to emphasize is the manpower, because without the trained manpower, it's a futile exercise to even think of starting a hospital or a PICU. You can have the funds, the money and wherewithal, but you need to first define your manpower, make sure your manpower and your team is set before you actually get started. The crucial part is training of those who are learning, who are going to join your ICU. There are many methods, both traditional versus modern, but it should be a two-way dialogue always. It's not didactic anymore. Teaching nowadays is a hybrid mode. Now we are doing online classes and online teaching, but at the same time, in our unit, when we train our fellows, we don't do any didactic teaching. We give them a topic, ask them to prepare, look up standard references, present in a PowerPoint or write on a board and explain to the rest of us, like as if we don't know anything about that subject. And that's the way to do it. Recruiting the right manpower with the right mix of skill sets is very, very important. You can't just directly put them into an ICU directly without proper orientation training. Also, you need to verify their training credentials. Are they actually competent enough to handle emergencies? Can they function alone? So on and so forth. Also important is mentoring all the staff that you have taken on board. You need to be a teacher, a guide, a friend, a father-like figure or a mother-like figure to be able to hold the entire team together so that they work with you and then provide the results that you're looking for. Nowadays, people keep jumping jobs and it's a common thing. We used to hear about it mostly in the IT sector and nursing sector, but in the medical sector too, you're facing these challenges. So retaining those whom you have recruited, whom you have trained, that's another challenge. And there are many ways to do that. Some of it is monetary, some of it is recognition, some of it is incentivization for various other things. That's very important long term. The key people whom you train should be with you for a long, long time so that your life is peaceful and you can work together with everyone. Well, getting on to the next topic of budgeting and costing. It is expensive. A PICU, setting up a PICU is not cheap. It's pretty expensive. I've just given a little sort of the slide has got a few salient points. Location, where should you locate the ICU? Most importantly, from your emergency room, you should be able to transfer a patient quite close to the PICU effectively without too much of a fuss. If you're part of a multi-specialty hospital, that's something which you can discuss with your administrators. Close to a radiology department, particularly CT scan, close to an operation theater, or it may be within floors where you have an access lift, which is dedicated for transferring sick patients. So time is not lost in a large multi-specialty hospital where you're waiting for a lift and the child is on the trolley, ventilated, and you're on a transport ventilator. That's not good at all. The cost of setting up can be anything from, these are all rough figures, 1,200 to 2,500 per square foot. This includes only the basic construction costs, air conditioning, a little bit of plumbing and other things. But again, there's a lot of variation in what sort of materials go into construction, what sort of air conditioning you're going to set up, especially for your infection control, positive pressure ventilation, or those rooms where you have a negative pressure rooms. So that's a different ballgame. It's a lot more expensive. The most important component after the civil part of the construction and setting up your ICU is that of your medical equipment. And this is where you have to be extremely careful in purchasing equipment. Just because somebody says we are the best or another big hospital has got X ventilator or this company or that company, it doesn't mean that you need to buy the same thing. Again, you need to have a costing as well as a budgeting for equipment. Number of pieces of equipment, ventilators, monitors, pumps, and all that. I would say the most important factor that you need to look into, apart from the price, is your after-sales support. Because these are machines and they run into problems day in and day out. And you must have access to their engineer, the company that sold you the equipment, who can come and fix it and take care of it. In the periphery, it's a big challenge, but I think some of the bigger companies, they do have branches and support systems in the districts. But in big cities, it's not much of an issue because they're readily available and we can just pick up the phone and call them and they're there within 10-15 minutes. Annual maintenance contracts. If you're buying equipment, it's important that you also have an annual maintenance contract which you decide, negotiate, and fix up upfront at the time of purchase. What really happens is the comprehensive maintenance contract for any high-end equipment, it expires after 2 years. So after 2 years, if your ventilator or whatever machine runs into a technical issue, you're stuck. At that time, if you approach the company, they're going to charge you exorbitant and you're going to get ripped off. It's important you decide as well as fix up the rate for annual maintenance contracts for at least 5 years and beyond, so that they are obliged to come and attend to your problems, and the cost of repair also, the components which they have to procure sometimes from abroad, it will be much cheaper for you. You also need a whole host of paraphernalia, drugs, fluids, oxygen. The list is very long. It's unbelievable. If you make a list, it runs into a few hundreds. So these things again need to be carefully factored and to get done. Again, you have manpower costs, the staff, you have to pay salaries to your doctors, your nurses, your registrars, your manpower, all that needs to be looked into. And you also have costs for non-medical infrastructure like furniture, computers, printers, so on and so forth. So all these are important when you're trying to start a new PSU anywhere. There have been some guidelines which have come up, and this is from our own intensive care chapter, which came in 2020 about recommendations for setting up a pediatric ICU. This article came in Indian Pediatrics. You can see the slide here. It's got a lot of details for a level 3 unit and a level 2 unit. But some of them may not be practical in terms of in a district hospital. You're asking for 100 to 150 square feet per bed. In a district, it may not be possible. And for a cubicle, 125 square feet, 200 square feet desirable. Again, it's very difficult to say how much can be done. The basic for level 2, you need all these pieces of equipment, ECG, monitors which have multi-parameter. They can monitor ECG, respiratory rate, saturations, NIBP for at least 50% of the beds. At least a few monitors you need to have, the little high-end ones with the modules for invasive blood pressure monitoring, pulse oximetry and all that. And of course, you need to have ventilators. Approximately, we calculate per PICU, 25% of the bed should be having a ventilator provision for invasive ventilation. That's the approximate ballpark. But again, you have to factor in where you're located, what sort of patients you're going to deal with, what sort of case mix you're going to get, and your referral base. So invariably, I'm saying as a rough figure, 25%. But if you're the only center for a whole district where all the sickest children are going to come, you might need much more. Half your beds need to have ventilator capability. So those things need to be factored and customized. Infusion pumps, warmers, so many other things are required. And it's important to have a proper crash cart. That's very, very important. Properly stocked, properly managed, checked by nurses every single day. An in-house lab is required, 24 hours access to blood bank, pharmacy. And if you can have the time to think of quality with all this happening, yes, you need to monitor quality parameters also. This is a general floor plan. I've taken it from our tertiary care center at Lagdi of the pediatric ICU. When you're planning a PICU, it's important that infection control is extremely important, as well as access to public and visitors. If you have a 2 or 3 layered method of access control, see from the elevators, public come out or a patient comes out, there's an access control here. They enter through a semi-sterile corridor, and then you enter the sterile zone. So when you enter from a sterile to a sterile zone, there's again the gowning, the washing and all that which happens. There's a wash sink right here. This is a PICU over here. Beds all spread out in the periphery. A central nursing station, it can be in any form of design. I'm just quoting this example where the staff can have a direct line of contact, visual contact with the patient. They should be able to see and monitor all the patients simultaneously and be able to access and look at monitors and look at patients directly. And then you need to have support areas like, for example, storage. You need to have an on-call room for the doctors, a counseling room, changing room, and so on and so forth. It's quite comprehensive, and a lot more things need to be factored in. If you have a department of pediatrics in a large multi-specialty hospital, this sort of a plan might be more convenient because it's not just pediatric ICU you're going to deal with. More importantly, management will say you need to have a neonatal ICU as well as other things. So this is a floor plan of our tertiary care center at Lagdi, which has got everything in one place. Half of it is the PICU, high dependency unit, and you have the access control here, through here. You have an operation theater and the neonatal unit here. I can tell you why it's so convenient here. The sick patient doesn't need to go far. It's very easy to transfer a patient. Say a child with a trauma, head injury, lands up in your ER, you stabilize the patient. You transfer the kid to the PICU, you ventilate, you do your osmotherapy and all those things. And then you have an SDH, which requires evacuation. It's easy for anyone to just shift the patient across the floor into the operation theater. The neurosurgeon does his part. The patient comes back to the ICU. Likewise for neonatal also, surgical unit plus the ICU are all close by. So it becomes easy and safe. I would say very safe for the patient. So these are factors to look into when you're planning an ICU. The emergency room, again, the location is important. It should be away from the general outpatient or the general lobby. It should never be clubbed with the same. The worst thing you want is public watching a sick patient who's bleeding, being wheeled into the lobby, into the emergency room, with everybody looking at what's going on. It's going to strike panic in the hearts of many people. That's not advisable. Your ER needs to be separate. Here at our center, we have a different floor altogether for the emergency access. Ambulances pull up here. The patient gets, the trolley comes from the emergency room here. They are wheeled directly to the ER. And we located our emergency room directly across the radiology department, both regular X-ray as well as CT scan under diagnostics. So whatever samples need to be sent upfront can all be sent off from the emergency room, and they can start processing them. In the meantime, you do your resuscitation, stabilization of the patient, and then shift through the lift to your ICU, whichever floor of ICU. By the time you reach there, you can get your lab reports and other images, CT and other things, and you can review the patient and do whatever is required. There are certain standards which have been set by the Directorate of Ministry of Health and Family Welfare, though this document I found seems a bit late, 2012, but I think more or less they have certain guidelines as well as recommendations for setting up district level and subdivisional hospitals. So this is a triage diagram which I saw, which I picked up from that particular document. You can see how a patient ambulance, a triage room is important, where the patients are prioritized. The sickest gets the attention most immediately, the urgent and not so urgent. The not so urgent are allowed to wait. The triage should be done in the emergency room as soon as possible. So the very sick child gets resuscitated, shifted to the ICU, go to the OT or not, ICU, and then to the general ward. Whereas not so urgent, they're treated and then dispatched from there. The levels of intensive care, I think the same document has documented and said service mix, what sort of service mix can you provide at a district level hospital? Say, for example, an asthmatic child ends up in your emergency room wheezing and hypoxemic. You can investigate, diagnose, treat, and if the patient, you have facilities where you can look after the patient safely, start the treatment in your ICU. If you cannot, beyond a certain point, refer early. The most important is refer to a tertiary care center nearest to you as early as possible. These are a mix of various disorders, diarrheal diseases, and so on and so forth. But where required, it's important to stabilize, refer early rather than late. This again from another document from Niti Aayog, Government of India, Emergency and Trauma Profile of District Level Hospitals. You can see here in district level, less than 300 beds, more than 300 beds. The bulk of disorders which end up in the pediatric ER and ICU, either febrile illnesses, respiratory disorders, gastrointestinal. You can see here, this is basically a bread and butter PSU work. Yes, you may get an occasional congenital heart disease, an occasional metabolic disorder, an occasional DKA, so on and so forth. But the vast majority, 75 to 80%, will fall in these 5 categories. Febrile illnesses, upper respiratory tract infections, lower respiratory tract infections who are sick enough, gastroenteritis with dehydration, CNS disorders, CNS infections, trauma, less common. I would say probably in the periphery where you're in a district level, you might see more poisonings as well as envenomation, scorpion sting, snake bites, and so on and so forth. But if you're starting an ICU, you should know what sort of patients are going to end up in your ICU so that you can plan accordingly, resources, manpower, resources, equipment, and ultimately to keep the cost low. Most important is when you're training your staff is having written SOPs, standard operating procedures. This is something from a hospital which we devised when the pandemic hit us 2 years ago. You can see it's dated 27th April. This was during the lockdown period, where you have a room where patients suspected of COVID land up. There's a triage room, and you have staff which are completely in a PPE kit and all that. There's if it's a respiratory, then they undergo a rapid test. They're shifted to a certain area. This is a flow diagram. I'm just citing as an example. Again, these are all again from the Surviving Success campaign. We're all familiar with these algorithms as well as how to go about resuscitating a sick patient effectively in a time-bound manner. Most important is things need to be done in a time-bound manner. For example, I can say in many hospitals, people struggle to get an IV access for a very sick child. You should not hesitate. There's a timeline for that. 90 seconds, you just stick an intraosseous, get the fluid on board, and then you'll be able to get your regular lines and everything else. Instituting therapy, most important, is more as crucial as everything else. So again, at the same time, once you have done resuscitation, you have to have a continuous reassessment. That's very, very important. So this is a diagram, which is a graphical diagram of a sick child. You can see various signs and symptoms all listed over here. But the earlier ones that you tend to see is tachypnea or tachycardia. Hypotension is late. Reduced capillary filtration is little late. Reduced level of consciousness means that your cerebral perfusion has been compromised. The patient is very, very sick. The earliest things you would see in a typical child with a febrile illness with either a lower respiratory tract or gastroenteritis is dehydration. So dry mucous membranes, oliguria sets in. So when you ask your focus questions to the parents, when was the last time the child passed urine? How many hours back? What does the urine look like? Was it good quantity or small quantity? Was it dark red, dark yellow, so on and so forth? With that, you're able to put together quickly how sick the patient is so you can prioritize your care. The sort of patients that you can deal with in a level 2 PQ are those which are relatively stable but need close monitoring. Crew, for example, asthma requiring nebulizations often, any child requiring more than 50% oxygen, those the DK who have a pH of less than 7.2, trauma, head injury, skull fracture admitted for observation, any significant abdominal trauma, or those with suspected renal, splenic, hepatic injury, any severe dehydration or mental status change, postoperative patients after major surgery, particularly abdominal, thoracic, cardiovascular, and any child recovering from a critical illness, but requires close monitoring. This is a bit of an extensive list of level 3 intensive care patients. We are all familiar with who is very sick, but you can see if you group together respiratory causes, lower airway obstruction, alveolar disease, unstable airway, comatose patients, meningitis, encephalopathies, cerebral malaria, trauma, poisonings, shock, septic shock, bleeding manifestations, again, congenital heart disease, hypertensive emergencies, renal problems, postoperative patients, those requiring ECMO and advanced therapies. These would constitute under level 3 care. I'm getting close to the closing part of my talk for today, but the most important thing, take-home points I would like to emphasize is to have a successful and a sustainable PACU, you require very good teamwork, great coordination between seniors, juniors. I think the most important thing is throw that something called ego out of the basket. Put it in a waste paper basket, forget about ego. There's nothing like that. It's a flat hierarchy. That's what we say, flat hierarchy. Even the junior most resident can say, sir, you forgot to wash your hands. If he has the guts to tell his HOD, sir, you forgot to wash your hands, that's a flat hierarchy. That means that he is telling it in the interest of the patient. There's nothing personal against you. He's telling it in the interest of the patient, and he's right. And I think that should be the culture that you have to have it. If you're able to retain a good team and you have talent which you can encourage people, give them incentives and strong referral base and teamwork, you can do wonders. You can do wonders in whatever setting you are. These are some of the challenges when you're setting up a hospital in the district level unit. First is manpower. The big question is, unless you have manpower, don't even think of starting a PACU. You should delineate, you should have an agreement, proper team already committed to a cause. Costing, you have upfront investment when you're starting a unit, then you have running costs, then you have recurring costs. All your equipment after 5 years are literally obsolete because there's so many components which require repairs, replacement, and that's a recurring cost. Some of them you may need to scrap. Again, depends on what quality of equipment you're buying, who is your manufacturer, what's their track record. These are all things. As important as your manpower and your service provision is equipment maintenance and servicing. This is extremely important because keep them in good working order so that you have a good life for your equipment rather than just junking it within 2-3 years for a simple problem. Handling patients and relatives, very important because this is where most people falter. You have to give them sufficient time. It is irritating, I know. You have to tell the same thing again and again to various sets of relatives who turn up and ask for how is the patient. But you have to have that patience, that compassion, as well as empathy and understanding. They are anxious, nothing wrong. They're anxious what's going to happen to their ward. And they have a right to ask questions and you are obliged to answer them in a very peaceful way without getting agitated. We see violence against healthcare workers. We have seen it during COVID, pre-COVID, and it's going to be there. We have to live with these problems. But the most important thing in preventing this particular thing which discourages us is communication. Effective, good, timely communication with the family, having a compassionate approach, showing empathy, that will avoid these problems. If you are going to tell them this child is not going to survive, there are very slim chances, we will do our best, pray to God. And nothing is in our hands, we will do what is capable, medically feasible. Most parents will understand. I know there are troublemakers, but you have to be careful about these things. Once you have set your PACU, quality assurance, how do you assure good quality care to the patients who end up in a ICU. That's very important. That's a whole different subject quality, and you can talk for 2-3 days on that. And if you are in a multi-specialty hospital, working and liaising with the hospital management, that's again crucial, so that you can work in peace and you can bring to them and have frequent meetings and discuss with them about problems that you're facing. And if you're lucky, you're in the right hospital management, they will listen to you, they'll help you run your ICU. And that's something which you have to be, it's an art and as well as a tact in managing people and your bosses. So I think it's important that way. Thank you for your attention and patience. I hope this was useful for those planning ICUs in a smaller level in a district or a medium-sized hospital. Thank you.
Thank you, Dr. Prasad Garu. Really, it's a great experience to listen to you, and you had informed us, you had given your 3 decades of experience in 20 minutes presentation. We are really grateful to you, and I'm sure it's going to be helpful to our clinicians who are intending to practice intensive care in resource limited settings in districts and small towns. Thank you very much, sir. Thank you.
Thank you, sir. Thank you.
Over to Dr. Anjul. Dr. Anjul, are you available? Dr. Anjul? Yeah, I'll do it. I'll do it. There is a small technical glitch. Please wait for a minute. We will rectify that.
Anjal made you the co-host. I think you can speak now.
Thank you, Shri Krishna, and thank you, Dr. Prasad, for a very lovely lecture. I think your experience of 31 years was reflected in the slides and the way you presented, and I think it's very important that the people who are setting up the PICUs in the smaller settings, in the rural area, semi-urban area, they will learn a lot from your experience. So thank you very much for giving us this lecture. Now I move on to Dr. Dinesh Chirla, sir, who will be talking to us about the refractory seizures. Dr. Dinesh, just before I started this meeting, I was saying that if I have to talk about Dr. Dinesh CV, it will take the entire day for me. He is the director of pediatric critical care in Rainbow Children's Hospital, and I think he has built up the Rainbow Children's Hospital to the stage where it is considered to be one of the best pediatric critical care hospitals of India. He has more than 20 years of experience, and he's going to be chairing the next IAP critical care chapter. And he is instrumental in bringing out 2 big pediatric critical care conferences in Hyderabad. Very approachable person. Whoever has worked with him, they know his work culture, his work ethics, and I think his academics are beyond par. I won't take much time between you and the audience. Over to you, Dr. Dinesh, sir, your presentation on status epilepticus refractory seizures.
Thank you, Dr. Anjul, for the kind introduction. Am I audible?
Yes, sir. Yes.
My slides are visible?
Yes, sir.
Yeah, at the outset, let me thank Dr. Bhaskar, sir, for being instrumental in getting everyone together and establishing the Telangana State Pediatric Intensive Care Chapter. Thank you, Dr. Bhaskar. I think you were the pillar who tried to get everyone, binding factor in trying to get everyone in, and I thank you for that. And I'm sure we have so many pediatric intensivists in Telangana State. It has a long way to go, and I'm sure it has a very bright future. All of us who have managed children with seizures, when it comes to sort of this, every unit has its protocol, and we know that over the last decade, there has some new evidence have come up. And as Dr. Bhaskar has said, the way we approached a child with sort of who has been sick has become more structured now. Now, when you look at the definition of status epilepticus, a working definition could be something like someone who's presented with seizures for more than 5 minutes. That's what earlier people would talk about someone for more than 30 minutes. But it could be further sort of divided into someone in the prodromal phase, that is in the first 5 minutes could be the prodromal phase. The 5 to 30 minute is the early status epilepticus phase. And once it is more than 30 minutes, it is the established status epilepticus. And the reason for this timings is so that you are more proactive in trying to control the seizures so that it doesn't become refractory. Now, there has been a more sort of international liaison against epilepsy has come up with a definition in 2015, where they have come saying that the definition against epilepsy is where there is a failure of mechanism responsible for termination of seizures or the initiation of mechanisms, which led to an abnormally prolonged seizures, that is, after a time point T1, or in a condition which have a long-term consequences. That is what sort of is what has been labeled. Why it is sort of said. So why are we worried about seizures? Because of a long-term consequences. So they have a different time phrase for a generalized convulsive status epilepticus. The T1 was 5 minutes and T2 was 30 minutes. That is time. Whereas for focus status epilepticus, it was 10 minutes and more than 60 minutes. And for absence status epilepticus, it was 10 to 15 minutes for the T1. So what you can, for a working, anyone who coming seizures for more than 5 minutes, you take it as a status epilepticus. This is probably for all the clinicians or fellows who have joined the this webinar. Anyone coming seizures, it is a priority for us to sort of control them. So when to use word refractory? You would use for refractory status epilepticus when even after administration to appropriate anticonvulsants at acceptable dose, which means one first-line medication, that is IV benzodiazepine, and one second-line medication, that is IV antiepileptics. So that is from 2001. Earlier, there was a timeline also given, like 60 minutes, which has been now 120 minutes as per the Brain 2011. And you use the word super refractory status epilepticus if you continue to seizures even after 24 hours, or there's a recurrence of seizures after 24 hours, even after using an anesthetic therapy, or when you're trying to withdraw the seizure anesthetic therapy, there's a recurrence of seizure. That is when you use the word super refractory status epilepticus. This is one of the way of, if you look at early status epilepticus in the first 30 minutes, established once it is more than 30 minutes. If you are sort of still after using an anesthetic agents, after you have use anesthetic agent, you say state refractory status epilepticus, and once after using benzodiazepine and an anesthetics, if you continue to seizure, that is where you talk about refractory, and the new 2011 guidelines talk about timing, but timing is not as important as talking about two anticonvulsants. And beyond 24 hours, it would be called as super refractory status epilepticus. Now, once we are clear about definitions, we then say, why does refractory status epilepticus occur? Either you have a very cause where you have a very severe infection, so the brain is knocked out very badly, or there is a damage. The damage could be there is excessive loss of GABA receptors. So there is an internalization of the GABA receptors. So there's a loss of inhibition, or this increase in the NMDA receptors. So hyperexcitation is there because of increased inflammation or increased blood-brain barrier permeability, increasing potassium level leading to hyperexcitation, which leading to increased calcium influx leading to apoptosis, or a mitochondrial failure leading to apoptosis. In short, if you have to say, there's a loss of inhibition, hyperexcitation, which continues will lead to apoptosis. Now, why it is so important for us to control seizures? Now, whenever there is seizures, initially what happens? There's a massive catecholamine drive. So there is hypertension, tachycardia, increase in central venous pressure. So with that, you somehow maintain the cerebral blood flow. But after 30 minutes, there's an exhaustion. You lose the autoregulation, and there is a hypotension and hypoperfusion. This is what we typically see here. Initially, there is a blood pressure is increased, the cerebral blood flow is maintained, but later there's a drop in the blood pressure, cerebral blood flow, and that is when the neuronal damage can happen and neural necrosis and long-term impairment can happen. So when a child comes with seizures, can you identify who's going to land up with a refractory or intractable status epilepticus? Someone who comes with encephalitic etiologies, severe impairment of consciousness, history of epilepsy, or a low anticonvulsant levels are very likely to have a refractory status epilepticus. So what are our goals of management? Terminate the clinical and electrographic seizures at earliest because seizures beget seizures. Definite control should be established within 60 minutes of onset of seizures. Every unit should have a predetermined status pathways. If you look at the literature, there will be differences of the dose. And I would talk to about that. So some would give levetiracetam at 20 milligram per kg, some would give 30, some would give 40 milligram per kg. That is based in consultation with your neurologist, and delay in status epilepticus management and a prolonged seizure is associated with the AED refractoriness. So anti-epileptic refractoriness is there. So this is one of the typical sort of recent sort of up to date. You sort of looked at how one of the units protocol is managing it. What you do in the first 5 minutes. So you would assessment and supportive care is one standard things. What you will do, you obtain the vital signs, you see whether the airway is patent or not, you initiate the oxygenation, you check the blood glucose level, and you would look at any other issue like either evidence of sepsis or meningitis or signs of head trauma. That is, as you are approaching the child, you are looking at this child. So you are administrating, clearing the secretion, administrating 100% oxygen, attaching the child to pulse oximeter. If the child is not breathing, you're initiating bag and mask ventilation. What does all this may suggest? That as much it is important for us to control the seizure, it is very important for us to maintain the oxygenation, maintain the ventilation, maintain the perfusion of this child, and also hypoglycemia. So these are very important when dealing with any critical ill children. So there's no point only for going ahead with the sort of, benzodiazepines without correcting this child. And if there's a fever, start with sort of, giving them acetaminophen. Now, what are the medications? The first line of medication in children is still benzodiazepines. So what do we do in a unit? We give lorazepam 0.1 milligram per kg IV. If you cannot get an IV and IO access, preferably we should start it within the first 3 minutes. Or diazepam 0.2 milligram per kg IV or IO. If you do not have, then meclobenzodiazepine or a nasal spray, or what we're giving 0.2 milligram per kg, or iammidazolam is also acceptable. Now, when we look at outside of hospital seizures, like if you get a phone call or if you have a paramedical, so there has been a lot of literature about what should be done. So iammidazolam is equally effective for children, say between 13 to 40 kg, 5 milligram of iammidazolam or 10 milligram of iammidazolam can be used. Or for those who have access to nasal spray, so 0.2 milligram per kg of nasal spray, which is now being very easily available, can be given to them as they are coming to the hospital for children who are where you can abort the seizure by the time they are reaching. If the seizure is still persistent by 5 to 10 minutes, that is when you have to consider repeating the dose of the benzodiazepine, but at the same time, monitor the airway breathing and circulation and consider sort of respiratory support if the child is not breathing. If you look at the evidence about midazolam, IM is as equally effective as IV lorazepam. This was sort of almost a series of 893 patients, a trial which showed that it was as effective as sort of lorazepam, and so was the nasal midazolam. In a trial where they compared there was a lot of things about comparing the efficacy of lorazepam and diazepam. And one of the concern about diazepam was the concern about respiratory depression, and many of us have shifted over to lorazepam. But when you looked at the recent evidence, probably the difference is not that much. Both are equally efficacious, but the effect of diazepam wears off very quickly compared to lorazepam. And that is the reason why I think most of the units still prefer to give lorazepam as first choice of benzodiazepine, compared to diazepam. But I think each unit can have it. Both are equally effective based on the evidence which is there. Now, beyond 5 to 10 minutes, once you sort of go from emergent therapy to urgent therapy, when you're loading with a second benzodiazepine, I think that is the time when you start thinking about going for your anticonvulsants. Now, what should be the first choice? Is it levetiracetam or phenytoin? Or phosphenitoin? The other medications which have been sort of looked at is phenobarbital and sodium valproate. Now, when there has been extensive review and systematic meta-analysis about all this medicine analysis of comparing levetiracetam, phenytoin, phenobarbital, and valproate, and all have been shown to be equally efficacious, anywhere varying from 65 to 70% in aborting the seizures. Now, the advantage of levetiracetam is it can be given very, it is safe and it can be given very easily, and that is the reason most of the units are now shifting to levetiracetam. Now, the dosage is one thing which has been sort of variable. Earlier, we used to start with 20 milligram per kg and then used to repeat it. But now it has been found that people are going to 30 milligram per kg, and some units prefer to go up to 40 milligram per kg also. When it comes to phenytoin, probably phosphenytoin is preferable, and the risk of, because of its water solubility, and you can give little faster, and risk of side effects like, arrhythmias and hypertension are less. But if it's not available, then phenytoin can be given. Especially in children who are less than 1 year, consider pyridoxine, giving 100 milligram IV or IM if the child is seizuring. And this is when you probably start thinking about neurologic consultations. And of course, you need to monitor the vital sign in these children. And this is what I was talking about. Shore1, who has done the looked at different anti-epileptics, levetiracetam, valproate, phenobarbital, phenytoin, and all of them, except for phenytoin, probably had a very similar efficacies in trying to abort seizures. So really, it is your, and for our unit, we use levetiracetam as our first drug of choice for. Many studies have been done. Say, ESET trial, that is established status epilepsy treatment trial, concept trial, or Eclipse trial. All this trial, the first trial compared levetiracetam, phenytoin, and valproate. The other compared levetiracetam and phenytoin, and all of them have showed that they all are equally efficacious as far as aborting the seizures or retaining the abortion. Compared to refractory seizures, repeat bolus of antiepileptics should be done, or should we go for intravenous midazolam is what. At the same time, the minute we go to the intravenous anesthetic agents, we need to remember that we need an access to mechanical ventilation, central venous access, hemodynamic monitoring, and look and treat infection, and you need a continuous EEG monitoring. I'll come to the other. So when do you need an EEG monitoring? Non-convulsive status epilepticus, differentiate abnormal movement, titrating anesthetic therapy, logistic continuous versus intermittent, and traditional. When do you need traditional EEG or amplitude integrated EEG? Amplitude integrated EEG, especially it is easy for the intensivist to read, but as a traditional EEG, you always need a neurologist to read for you, and majority of us would read these things. Now, let us take this scenario. A 7-year-old, 5-month, 7-year, 5-month-old girl presented with history of moderate to high-grade fever. For 2 days, she had vomiting, she had right focal seizure followed by secondary generalization. She was being treated at a referral hospital. In the initial episode, controlled with benzodiazepine and levetiracetam loading of 30 milligram per kg, had multiple episodes of seizure, each lasting between 5 to 20 minutes. She was read levetiracetam 60 milligram per kg, valproate was given, and phenobarbital was given. She's hemodynamic is stable, continued to have seizure, and that's why she referred to tertiary hospital. All her blood reports, the glucose, electrolyte levels, calcium, magnesium, complete blood counts were normal. CBP, CRP was normal, renal functions, hepatic test ones were normal, and blood cultures, lumbar punctures. So there was no evidence of infection, CT head was normal. This is when you would say, now question is, would you wait for 3 anticonvulsants before shifting to IV anesthetics, or after optimizing 2 anticonvulsants, we should shift to IV anesthetics, which varies from unit to unit based on whether the child is a known seizure and person with epilepsy, or many of us would shift to IV anesthetics after you optimized with 2 anticonvulsants. Someone is actually writing something on the screen. I think I'm just getting a lot of this thing on the screen. I'm not sure. So what are the formal?
I request the people please refrain from trying to do these things on the slide. It's actually disturbing us. Thank you.
So, what are the anticonvulsants which are anesthetics which are being used? One is midazolam, which is sort of modulates it acts on the inhibit sort of GABA receptors. So loading dose of 0.2 milligram per kg is administered. An infusion rate of 2 milligram per minute is given, and we'll come to that in a little bit more detail. The other anesthetic agents which are used are pentobarbital coma can be induced, or thiopentone. And again, both act on the similar spectrum on GABA receptors. 5 to 15 milligram per kg of loading dose for pentobarbital, and thiopentone is 2 to 7 milligram per kg is given, and then it is titrated at sort of 0.5 to 5 milligram per kg per hour for pentobarbital, and 0.5 to 1 milligram per kg, and up to 5 milligram per kg per hour for thiopentone can be maintained in thiopentone till you achieve the burst suppression pattern. Propofol is also used in some children who are resistant, but we usually avoid propofol in many children, especially for those who are smaller and those who are having metabolic acidosis or those who are on ketogenic diet, because of risk of propofol because of the sort of the typical sort of propofol-induced respiratory acidosis, which we get in what you call a PRIS, where you can have a metabolic acidosis and rhabdomyolysis in these children and hypertriglyceridemia. So these are the typical what we call a propofol infusion syndrome, which is caused. And of course, ketamine is used sometimes specifically in children who have been on prolonged sort of midazolam or thiopentone infusion, still having, because the mode of action of ketamine is different. It acts on the NMDA as an antagonist. So that has been used in some of the children on 0.5 to 3 milligram per kg. And this thing is isoflurane anesthetic has also been used if the patient doesn't respond to any of this. Now, how do we decide? So as I said, the risk of hypotension, it is less in midazolam compared to the other agent. So cardiorespiratory depression less than others, tolerance and withdrawal seizures. So the tachyphylaxis is more with midazolam, and the risk of renal hepatotoxicity is more. Whereas with thiopentone, for those who use thiopentone, they know that is neuroprotective, reduces cerebral metabolism, but it has a long duration of action. So once it suppresses brain, you don't know how long it will take to clear from the body. So once the child is knocked down, I know whether the child is not responding because of the drug, or child is sick and not responding, you do not know. So, and there's a risk of significant hypotension. Of course, phenobarbital, pentobarbital coma is another. Propofol, as I said, propofol infusion syndrome, and ketamine, no hypotension, and we'll use specifically as a second order. Now, why so many are there? So there have been no randomized control study to say which one should be used. The choice of anesthetic agent is often individualized. Unfortunately, due to the lack of randomized clinical trial to guide clinical practice, the goal of pharmacologically induced coma, that is termination of seizures, whether burst suppression or complete suppression of EEG activity, how long to be given, there is no clear evidence when we look for it. So most of the units, the first choice is still midazolam infusion, where nearly 73 to 80% of the seizures can be controlled by putting on midazolam infusion. If they're not controlled with midazolam infusion, people either would go for pentobarbital coma or a thiopentone coma. Propofol by used is still, it is little more popular in adult children, a little careful when it used to propofol. Ketamine is also used by some of the neurologists when it is sort of refractory seizures. Especially this, we talk about super refractory seizures. So after giving the bolus, then go on titrating. But once the children are on this type of infusion, we need an EEG and invasive blood pressure monitoring. Because once they go on to the anesthetic agent, they are very high risk of developing hypotension. So we need to see that if required, they may need inotrope. Maintain them seizure-free for 48 hours and then slowly taper afterwards. Ensure causes identified and treated. And so ensure that there is adequate anti-epileptic drugs, doses. So coming back to our case, child was shifted to Tertiary Children's Hospital. Midazolam infusion was started at 5 microgram per kg per minute, along with continuous EEG monitoring. Child continued to have clinical seizures. So we went on increasing till the child reached 20 microgram per kg per minute, which is almost 2 milligram per kg per hour. And child was monitored. Once the child was stable for 48 hours, during this phase, we started investigating. And whenever, what are the causes of refractory status epilepticus, super refractory? We look at infections, epilepsy, look for non-compliance of drugs, autoimmune encephalitis, febrile induced refractory epileptic seizures, new onset refractory epilepticus, structural lesions, hypoxia, stroke, drug toxins, metabolic and genetic disorders. So new onset refractory status epilepticus, the cause found later in 50% is infections or autoimmune. Whereas febrile infection related epileptic syndromes, which is typically seen in children between 3 to 15 years, has an unknown pathogenesis, and they again respond to immunotherapy. So typically workup for children who are having seizures like this should be blood culture, sending like typically infective workup is sent up, neuroimaging is done, and looking for any hypoxia, encephalitis pattern, any congenital lesion, and also autoimmune workup, ANA, NMDA receptor, VGK receptors, voltage gated potassium channels, store some sample and feed fit for the rare antibodies, metabolic screening, and toxin drug levels. So you might find features like some viral encephalitis, or you would find bilateral thalamic frontal lesions. You would find right frontal focal cortical dysplasias could be found, which will explain, or have a big hemimegalencephaly. So that will explain the cause of seizures. This child, after you tried to reduce his seizure medication, the midazolam, the seizures reappear. The question comes is what you should do when the seizures reappears when you try to reduce the midazolam. That is when the non-GABA acting seizures can be considered, like lacosamide or topiramate can be considered. This and minimize and treat sort of complications. Use of cycles of coma maintained for 5 and tapered very slowly, or target alternate therapies. So in spite of topiramate, the child did not, seizures continued. That's when thiopentine infusion was started, 2 milligrams per kg per hour after loading with 5 milligram per kg, and was started up to 5 milligram per kg per hour. And because the child had hypotension, we had to start the child on dopamine and EEG monitoring. So what is the endpoint when you are on thiopentone? You need to have the burst suppression pattern, which is sort of, this is a child whom sort of is on thiopentone infusion. And you can classically see that this child is on a burst suppression pattern is there. So when you retrieve that, this is the child, suppose you have most of your investigations you look at have come back normal, CSF normal, viral panel normal, respiratory second panel, and sometimes very frustrating, EEG showing seizures, and sometimes autoimmune workup has also come back normal. That is when, you would consider, and I'll come to some of the other modalities, but these are the children there when inhaled anesthetics can also be used for seizure control. And this is where we started using isoflurane in these children and this child to control seizures. And the isoflurane can be given inside the ICU to control seizures, and it acts beautifully. Again, there's risk of hypotension, and this children sort of could be sort of after isoflurane 36 hours, we could control both electrographic and clinical seizures, and he was discharged after 45 days of hospitalization. So in suprarefractory status epilepticus, once general anesthetics are used, and we need to, if you are able to find the cause, then treat the cause. If there's a focal lesions, that's when the surgery could be considered. The other things which are IVIG, and I'll come to that, and hypothermia and ketogenic diet. So what is immunotherapy? So when you have a child where NMDA receptor or voltage-gated potassium channel receptors are positive in a child who is continuing to have seizures, in spite of your anesthetic agents, you can consider giving them steroids. That is, majority would give methylprednisolone, some would go Dexa, or giving immunoglobulin 1 to 2 grams is given. People would go even for plasma surface is also given in some of the children. Lokesh has a huge series of patients who even went ahead with plasma surface, and even biologists like rituximab has been given. And very rarely, some of the children will require cyclosporin or cyclophosphamide to control the seizures. Ketogenic diet has been used as maybe because of its anti-inflammatory mechanism, where the ratio of fat to carbohydrate and protein is kept 4:1 to induce ketogenesis. 24 hours fast before initiation. may take time for ketosis to be achieved. Monitor the blood sugar, ketones, triglycerides, and bicarbonate level, and avoiding fatty oxidation disorders, and along with propofol, as I mentioned before, because of propofol infusion syndrome. In very rare cases, we induce hypothermia. Some would say 30 to 31, some would say 30 to 33 degrees centigrade for 2 to 5 days. It reduces cerebral metabolism and may be neuroprotective. We have to look for complication of hypothermia, monitor the heart, monitor for PPHN, look for platelets, and treat fever aggressively. Look for other therapies like transcranial magnetic stimulation, vagal nerve stimulation, deep brain stimulation, electroconvulsive therapy, and cerebral spinal fluid drainage, and newer drugs like brivaracetam. Whenever one child becomes as sick as this and is on ventilator and so many medications, they're really knocked out, they're high risk of developing pneumonias, hypotensions, and bacteremia compared to the non-refractory status epilepticus patients. Remember that whenever you have a child with status epilepticus and you treat them, the 20% of children can have a non-convulsive status epilepticus. The risk factors are those who have epilepsy or remote etiology. Toning deviations of eyes, lip twitching, and autonomic changes are the clinical clues. This is, if you put a child on EEG, you'll come to know that's the only way you can pick up a child with non-convulsive status epilepticus. And once you do a EEG, you'll come to know how it sort of, following lorazepam, it sort of EEG gets normalized. There is a role of surgery in refractory status epilepticus when nothing is working, especially cases like focal cortical dysplasias, and where sort of seizures will get aborted by surgical interventions. And we have a series of patients who have sort of where surgical correction was done for epilepsy, and these children sort of recovered only after surgical interventions. Once you go to the status of suprarefractory status epilepticus, the prognosis is not very great. The mortality is 30 to 50%. The deficit risk is nearly 35%. Poor prognostic factors are based on the underlying cause, or if it lasts for more than 10 days, and if the burst suppression and isoelectric line is for its very long period. And if usually when you're on prolonged ventilation, you're on tracheostomy, neurorehabilitation, parenchymalin is for sometimes more is required, and you have to talk about this to the patients. To summarize, it is always good to abort the seizures very early. So have a structured protocol in your unit to control the seizures. If you abort the seizures in the first 60 minutes in a protocol way, that is your best chance. But there are some children who are at risk of refractory status epilepticus and super-refractory status epilepticus based on the etiology. Once they go into sort of needing IV anesthetic medications, they will need a level 3 PICU. They need invasive blood pressure monitoring. They'll need EEG monitoring, and the risk of morbidity and mortality significantly increases. So it is important to take, we need a multidisciplinary care. You need neurologist involvement. And so it is better to be sort of treated with a consultation with a neurologist. There's a huge sort of advances in terms of role of immunotherapy, role of plasmapheresis, steroids, and sort of surgery in some cases, especially when you have super refractory status epilepticus. So with this, I end my presentation. Thank you. Open for questions.
Thank you, sir. It was a wonderful lecture, sir. And I just wanted to bring everybody a secret that Dr. Dinesh sir has an ability of making the complex of the lectures very, very simple. And that's why in most of the programs, he's given the most difficult of the lectures to present. And it is a wonderful lecture, sir, such an extensive one. And you have brought out points so wonderfully well and so eloquently. I don't see any questions in the chat box as of now, and I'll request all the delegates and the people who are attending, in case if they have any questions, to please write it down in the chat box. If there's no further question, we will go to the next lecture. And before I start the next lecture, I'll hand over the podium to Dr. Bhaskar sir. He wants to talk a little bit about the next lecture and the speaker, and then we'll go forward, sir.
Thank you, Dr. Anjal. Thank you very much. And I'm sorry, my apologies to the participants because I'm again coming in between the academic program. But I'm tempted to talk about Dr. Suchitra Ranjit because you know about her. She's a legend in the pediatric critical care in India. So I thought I should say a few words about her, though I know little. Thank you, madam. Thank you for accepting our invitation to be part of our faculty at IAP Twin Cities Branch Symposium. Here I should thank Dr. Dinesh, who could fix or who could invite and successfully Dr. Suchitra to come on to this session. Just to recap her contributions, she made a tremendous contribution to the pediatric critical care or pediatric intensive care in India. She belongs to the first generation of pediatric intensivists, and also she was a founder member of this chapter, chairperson of IAP IC chapter. I was in your absence. I was telling madam, I am practicing since last 35-36 years. So we were all afraid to start pediatric critical care units, and we never ever used to have these hi-fi units. At the most, we try our best to control the seizures. We used to provide some raw oxygen. Somehow we could manage, but so much changes had come, probably because of you, all the intensivists, and you're one of the few among them. And main reason for talking to you here is we knew Dr. Ranjit way back in 1995 or 96. He used to visit CDR Children's Hospital, wherein we used to admit most of our critical cases at CDR Hospital. And Dr. Ranjit sir used to come from Chennai once in fortnight or once in a week, along with Dr. Balakrishna, an eminent pediatric cardiac surgeon from Chennai. That time he used to work in Railway Hospital. So we used to have good interaction with Dr. Ranjit that time. So I thought I should reveal this in front of all the participants. And secondly, I'm thankful to Rainbow, particularly Dr. Dinesh and Dr. Ramesh and Dr. Farhan. When my daughter wanted to join in pediatric intensive care as a fellow at Rainbow, they had encouraged me and they had accepted her to be their fellow trainee, but they warned me that whether she can do this or not, because intensive care chapter is a little exhaustive one, is mainly done mostly by the men. That time, again, I remembered Madam Dr. Suchitra, I remembered you. I told to my daughter to take up this pediatric intensive care. But destiny is written in a different way. She went to US. She's doing her fellowship in pediatric gastroenterology. So we are very grateful to you, Dr. Suchitra, madam. You are a jewel in the crown of this IAP TCB symposium. I welcome you to the symposium. Thank you.
Okay, thanks. Yeah, thank you very much for that. Thank you, Dr. Bhaskar, for that, some personal, individual connections. So that was good to hear. Thanks, Dinesh, for inviting me. There's a big lineup of illustrious speakers. So I think I have a problem sharing on this. It's a new system I'm using. Can I just send you the link to Dinesh Anjul and then just, is that okay? Yeah, I'll just send it to both of you. I'm just using another system and it's not permitting me to share for some reason.
Dr. RSV, are you there?
In the meanwhile, yeah. So sorry about that. If you...
It's okay, madam. Take your own time.
Okay. So I'm just sharing this with Dinesh and
Dr. Anjal, can you introduce a formal introduction about the madam?
Yeah.
Yeah, sure. Yeah, I'll be more than happy.
Suchitra, you're emailing?
Before that, I would like to say Dr. Anjal was trained under Dr. Sujitra Ranjit at Chennai. Yeah, over to Dr. Anjal.
Yeah, so yeah, it's my honor to introduce Dr. Suchitra ma'am. Whatever intensive care I know, I've learned from ma'am, and Dr. Bhaskar sir has already introduced about that she's been instrumental in starting the pediatric critical care formal training in India. She was a part of that core group which started this formal training of pediatric intensive care. And right now she's the director of Apollo Children's Hospital, which is rated as one of the best tertiary level referral centers for pediatric critical care. And apart from that, she's an international task force member of pediatric surviving sepsis campaign guidelines in the definition committee, and also the Asian representative of board of director of World Federation of Pediatric Intensive and Critical Care Society. Her interest is septic shock and dengue. We all know that. We always keep on hearing and learning from ma'am about the septic shock, and she has extensively published a lot of literature in the various national and international journals. And yeah, so I think ma'am has sent it to me. I'll just try to see if I'll just
I'll do it, Anjul. I'm just doing it. So okay, you can carry with your this thing. So I know you bring, I'll just share it.
Yes, sir. You are the co-host, so you can share the screen.
Yeah. I'm just downloading that.
Do is I'll open it on my, and I can join via my phone as well. Is that okay?
And then I'm done with it. Just give me 2 minutes. Yeah. I just downloading it. So
because there's a lot of animations as well.
Yeah, that's why it's taking time, yes, ma'am. So
yeah, can you see that?
Yeah, wonderful.
And
the only thing, maybe I can ask, there's a lot of animation, Dinesh.
I'll do it.
Keep you a little busy.
No, it's fine. Yeah.
Okay.
Fine.
Okay. So thank you again, and I apologize for that confusion. In the next 20 minutes or so, I'm just going to discuss about what as a general pediatrician with interest in emergency or critical care, what we can do to stabilize the child, how we can recognize early, how we can stabilize. So the first few hours is the most critical. And if you do it right, the child can have, even after you send to a good ICU, the child can have a very smooth and successful outcome. Next, please. Next. So just 3 major points, how to improve early screening, and what influences your choice of antibiotics, how you will resuscitate and monitor children who are getting fluid boluses, and how you would choose the initial vasoactive inotrope regimen in children, and what are the common mistakes. So this will be the outline. So when you talk about early recognition, it's essential to have sepsis screening tools. This has become very common in children's hospitals with successful sepsis outcomes, because children with sepsis, they'll come with a pneumonia, they'll come with a urinary tract infection, with a cellulitis. The fact that there's a bacteremia and other problems going on will not be very evident unless we look for it. Next. So all children's hospitals must have one screening tool. There are many, many screening tools if you look online, and some are a little complicated, some are easy, but have one that works in every ward, outpatient, emergency, ICU, operating theater, recovery. So if you, the next, just click. So if you see here, this particular one, next. So you can see here, for example, no, sorry, just go to the previous one. So if you see here, sometimes a heart rate of say 150 can be bradycardic for a will be tachycardic at some ages and bradycardic at others. So a screening tool will give you, it's a quick way to recognize if what you monitor is correct. Obviously, you need age-appropriate blood pressure cuffs. You need to measure the respiratory rate for about 20 seconds or so. So according to the age, you can just tick mark on these red boxes if the patient is satisfying these. And depending on 3 or more boxes checked, there's a high likelihood of sepsis in addition to the primary diagnosis, and we should highlight and escalate the whole treatment regimen. Next. So this is from the National Health Services. Says red flag. This is another thing that must be highlighted and prominently displayed in many and wherever sick children are treated. So even low temperature can be a worry. Apart from high temperature, altered mental status, which you can't explain, respiratory rates, inappropriate tachycardia, prolonged capillary refill. And if children are younger than 3 months, have chronic disease, recent surgery, you would have a lower threshold of suspicion. And early recognition certainly is the way to go to improve outcomes rather than when they come late in a decompensated state. Next. So once you suspect sepsis, this is called sepsis 6, right? So I just highlighted these points because it's easy to teach, easy to remember, even for nurses. So you give 3 and take 3. So give oxygen, and earlier we were giving oxygen to all comers with sepsis, but now we know that it's only if the SATs are low, that are less than 92 or so. Give fluid, so it's not automatic large volume fluids, but the initial 10 to 20 ml per kg is probably helpful and not harmful in most children. If the blood pressure is low, initiate early vasopressors. I'll go on more on these later. And the third, give us, depending on the spectrum, depending on the cause, a broad spectrum antibiotic. I have one slide on this. So you need to take blood cultures. A common mistake is to take only one set, saying blood culture is expensive, but it's important that you take 2 sets of blood cultures, do a gram stain of whatever specimens you get. You need to identify the organisms and narrow your antibiotic choice. Take blood gas with lactate and insert a Foley catheter very early so that very early on you know whether your treatment is on target or not. So give 3, take 3, easy to teach, easy to remember. Next. The choice of antibiotic really depends on the presence of shock and organ failure. I'll give an example in the next slide. So there are important indications for giving the highest spectrum and broader spectrum of antibiotics. Think of the focus on etiological agents. If a child has a pneumonia or a meningitis, so that choice is important rather than giving Miro-1 to all comers with suspected sepsis. Think whether the child has, this is easy enough to recognize, has a child come to the hospital with a community-acquired infection come from home, or is it hospital acquired when it's more likely to be resistant, and the presence of high-risk condition that place the child at higher risk of infection with resistant organisms. Next. So how will you decide, for example, a child comes with pneumonia, how will you decide whether there's also sepsis or is it just a bacterial pneumonia? So you look, your antibiotic choice depends on the severity of the pneumonia, of course, and also signs of dysregulated immune response. Now, in the OP or clinic or emergency, we can't do cytokines levels. So how are we to know if they have a dysregulated immune response? So the clue is if there is shock or a remote organ failure. What do I mean by a remote organ failure? So the child has a pneumonia, but you find the creatinine is up. The child has a pneumonia, or the platelets are down, or the liver enzymes are increased. That means there's a bacteremia, there's a dysregulated immune response, and other remote organs are failing. This is a very important clue that it's significant the storm is building up. So you better nip it in the bud with higher antibiotics immediately. So in a bacterial pneumonia in the ward, no organ failure, shock, augmentin, macrolide will do. Whereas if it's a bacterial pneumonia with shock and elevated other organ involvement, you might need to broaden the cover. Next. So as I said earlier, good microbiological support is essential. I always tell the story of a pediatrician in Port Blair in Andamans who sends patients regularly, and he actually ships the blood culture bottles across, gets results from a good lab in Chennai, and then fine-tunes his treatment. So it's that important. Never think of economizing on microbiological investigations, because you need to get the organism, treat it well, and narrow your spectrum will help your next patient as well as the patient in front of you. So identify the organism's sensitivities, look for adequate source control. Sometimes you identify the bug, you're given sensitive organisms, but shock and organ failure not improving. Look for empyema, collections, anything that's preventing your antibiotics from working. Next. So we talked about early screening, recognition, choice of antibiotics. And I'm going to spend a little more time on initial resuscitation with fluid boluses. Anjul might remember at the time he was with us, that means, when was this, about 18 years ago, the practice was to give large volume fluids to children who came with shock. So it was almost a race, push and pull, the faster you give, the better. So there were papers on how fast you could give the 20 and 20 and 20 ml per kg fluids. And that's all kind of fallen in disrepute. So it's not that fluids are bad, but maybe large volume fluids are not appropriate for many people. And this is an excellent paper, although it's adult based, it's very, very applicable for children as well. So really the physiology of hypovolemia and sepsis is explained fabulously, as well as the approach to treatment. Next. So basically what we see in most patients and adults and children, that more than absolute hypovolemia. For example, they may vomit a bit or have decreased intake. So that is absolute hypovolemia. More than absolute hypovolemia, it is relative hypovolemia in septic shock. That means they haven't lost the body from the lost fluid from the body, from the system, but is actually sitting in the wrong place, is redistributed. So and the most common place where that the circulating volume is pooled and not coming back to the heart is a dilated venous capacitance vessels. Next. So you can see here the venous capacitance vessels are massively dilated. This happens on the arterial side and this causes hypotension, but the pooling on the venous side leads to decreased venous return. And if you give a lot of fluids, you can overcome some of the shock, but it's a short-lived, it's a easy fix that doesn't have a long-term solution. So if you have a dilated arterial and a venous system, rather than large volume fluids, what might be a better deal? Next. So just a little more about this. If you are the pediatrician facing a patient and you're given the initial 10 or 20 ml per kg, the child is still in shock after that 20 ml per kg. So the common thing is give more fluid because it's so easy, it's available, it's cheap. It's like you don't have to think, just give one more fluid. So it's easy, but it may not be the right thing to do. So further fluids, the first bolus by all means, go ahead, it buys you time. You can do a lot of things in those 20 minutes. If you have a bedside ultrasound, by all means do it. If you don't, it doesn't matter at all. There's a lot of clinical signs that are helpful. So if you think further fluids, certainly there's ongoing losses. A child with a drain, who's vomiting, who's got diarrhea, certainly give more fluids. But otherwise, next. Next. So if if we give a lot of fluid, this is typically what happens. Or if you give aggressive fluids in the first few hours, a lot of fluids, lot of inotropes, this can keep the ICU very busy for the next few days. So maybe the hospital administration will be happy you're keeping all beds full and all the technology and equipment busy and occupied, but may not be in the best interest for the patient. Next. This is because fluids lead to a greater need for rescue ventilation. Maybe they wouldn't have needed it, but we're given fluids. Now we have to save them from that fluid and rescue them. Greater need for rescue inotropes because myocardium also can get boggy and edematous. Greater need for rescue dialysis, longer ICU stays, and worse outcome. We show this very clearly in a paper of ours. I will allude to it very briefly. Next. So there's very clear literature on adults, but what about children with septic shock? Next. So all of these happens in the first hour, and usually in the emergency room. How should the clinician monitor a child who's receiving fluid bolus? I've tried to make it easy. At every step, whether you give fluid, pressor, or inotrope, it's a test. And you look at 3 endpoints. And what are they? Next. You look at flow, whether the child is perfusing well, look at the pressure, and look at filling. Okay, I'll explain this further. So every time you do any intervention for a child with shock, you look at all 3, not just one or the other, not just the blood pressure, but also the pulses and also evidence of congestion. Next. Next. Keep going. Next. Next. So let's look at the first part, the flow or cardiac output. What do I mean by this? So when a child is in shock, it means there's less flow, and that less flow is taking less oxygen to the tissues. So tissues are going into anaerobic metabolism. So when we treat shock, we want to improve the cardiac output, thereby improve the tissue oxygen delivery. We cannot measure this, it's very complicated. So what are our surrogates? There's one easy one if you have an arterial pulse, arterial line is to look at the pulse pressure, the area under the curve. Other ones which are even easier, next, are looking at microcirculatory markers. So measuring cardiac output, blood pressure are macro. Microcirculatory markers are as important or even more important. This would be extremity temperature and color, capillary refill, hourly urine trends. And if you have blood gases, you can do other tests. Remember that lactate, a very common problem is that lactate can remain elevated. You're chasing it, and sometimes that gets you into over-treatment. Lactate is cleared very slowly in sepsis. If there's liver involvement, it becomes even slower. There's a very super article called Andromeda Shock Trial in JAMA from Latin America that showed that if you chase lactate, you end up over treatment and over giving too much fluid. Capillary refill is much faster and more reliable and leads to better shock resolution with less treatment. So that's a very good that's a very good lesson and a message for all of us in India that we don't have to keep chasing blood gases and lactates. Just a capillary refill is good. Next. So the second part, we talked about flow. The second part is adequate vascular tone. Vascular tone. So it means this is not only the mean arterial pressure, it's also the diastolic blood pressure. Next. Remember that even suppose your cardiac output improves. So that means the pulses which are absent, the extremities that are cold have now become warm. You can feel pulses. That means the cardiac output has improved. Even if the cardiac output has improved, in some children, fluids can vasodilate and the map can fall. We've shown this in children as well. So you need to balance flow with an adequate vascular tone. Both are important. Why is this so? Next. So we've shown in our two populations of children that after cardiac surgery next, and in septic shock, fluids can vasodilate next. So we showed that fluids improve the cardiac output in MAP in about 1/4 to 1/3. Very weak association between the two, but about 50% required a higher vasopressor dose after fluids, suggesting that in about little over half, the fluids were vasodilating as well. So suppose you give fluids, so you're happy that tachycardia seems to have come down, the peripheries are warmer, and you think, okay, MAP's a little lower, diastolics are most people don't even look at the diastolic. So we say MAP is lower, maybe we'll give some more fluids. But remember that the lower MAP can decrease perfusion pressure. So don't bother if you don't, you don't need to remember this too much. All you need to remember is look at the diastolic. If the diastolic pressure is coming down and the pulse pressure is widening, you may be improving one problem at the cost of worsening another problem. Next. So when the perfusion pressure is low, it can impact especially lower diastolic. Literally the heart of the problem, the coronary circulation is impaired, and that can cause myocardial ischemia. So always watch both the flow and the vascular tone, especially the diastolic BP. Next. So the third part, we talked about cardiac output, we talked about vascular tone and filling. And this is very obvious, a child who's looking edematous, large liver, and if you have an ultrasound, you're showing evidence of congestion. So we need to prevent congestion, we need to optimize cardiac output, and we need to maintain the vascular tone. If you think of it, you can auscultate the child. It's not hard, even without an ultrasound, it's not hard, but it requires somebody in the bedside, somebody, preferably the same person who you need to assess the child, monitor the child. So that is a part that most of us find it hard to stay at the bedside because we've got 100 other demands on our time. So if you do, it's not that you need a tertiary level ICU to give that superb first 1 or 2 hour care. You can give very good care provided you have to stay at the bedside. Next. If you have facilities for ultrasound, there's something new come up about venous ultrasound, and my colleague Dr. Rajeshri is doing a lot of work on this. Basically, it's called VEXUS, which means venous excess ultrasound. There's grading for it, and it's got a lot of importance and requires a whole talk in itself. So I'm just introducing the concept. Venous congestion can have a lot of detrimental effect. We don't think about it that much. We just think congestion means fluid overload. It means wet lungs, give a bit of diuretics and PEEP. It'll all go away, but it may not be so simple. We just go to the next, Dinesh. So this is a photo taken in the emergency room. Okay, this child has just been intubated but no other lines. And how can we decode the physiology of pediatric septic shock? What we are learning with all the time with every child is that each one likes to carve his own path. They like to be different. They don't want to be lumped together like cattle that you give 60 ml per kg and then go to dopamine or epinephrine. Each one is different, and you need to find what the child needs, what is the physiology, and tailor your treatment accordingly. Make it a very personalized treatment regimen. Next. So if, as I said, the child is telling you a story when you give a fluid bolus, what is happening to the pulses? What is happening to diastolic BP? What is happening to congestion? Each is different. And if you monitor carefully, you can easily detect if this cardiac output or the clinical markers of output have improved or not. Has it deteriorated? Has a MAP and diastolic BP increased or at least not fallen? Are there any features of fluid intolerance? So none of these needs complex monitoring. Just these 3 points: cardiac output, pressure monitors, pressure parameters and fluid intolerance. In case a map falls or there's fluid intolerance, don't bother with more fluid, just go immediately. So this is a test of the circulation. The child is telling you a story, make the points and make your next step based on the child's story. Next. So again, just reiterating, you're monitoring cardiac output and perfusion. One is cardiac output perfusion markers, second pressure parameters, third is filling or congestion to decide on your next step. So after fluid, the perfusion is same, pressure is same or better, no congestion. Yes, please give more fluid if the shock is unresolved. But if the perfusion is same, but MAP is same or lower, and the diastolic BP is fallen. Remember, the heart is getting less oxygen, there's coronary ischemia setting in. Even if there's no congestion, we will not give more fluid, just start a low dose pressor via peripheral line. Next. So the third possibility is that perfusion and tachycardia is worse, but pressure is the same and there's new onset congestion. This tells you, even if you don't have an echo, that the heart is struggling. Even that has been a test of the circulation. So the child needs inotropy. Look at the BP. If the pressure is good, start dobutamine. If the blood pressure is low, start epinephrine. So it's actually not too bad at all, your decision whether to give more fluids or inotropes or pressors. Next. So I've already alluded to the choice of vasoactive inotrope infusions. And just briefly to stress a few points. Next. So certainly early, though, there's plenty of evidence that both in adults and pediatrics that early low dose vasoactives. So I'm stressing the low dose. A temptation is to go to higher and higher doses when children are not getting better. But low doses actually work much better. You need to lower your target sometimes. And I mean, that is a better strategy than giving very high dose fluids or high dose vasoactives. This results in sustained hemodynamic improvements and decreased need for IC support. Next. So this was a study that we published, I think it was almost 10 years back, really, that if you give a vasoactive such as epinephrine, we think epinephrine only acts on blood pressure. But remember, I showed you the diagram where the entire venous system is dilated. At low doses, it gently squeezes the dilated vascular bed and the venous system, improves venous return without a drop of fluid. So it's sustained, you're not fluid overloading, and you've got improved venous return. It's a win-win kind of strategy. It also has very mild beta-1 effects. So it also improves cardiac output. So we measured all of these because it was a research study. So we could measure the cardiac output, show it increased, measure the systemic vascular resistance at each point. And we could show that children who with this strategy, that means after 20 ml per kg giving norepi, less days on ventilation, less need for dialysis, less time in ICU. Next. So it's literally, I mean, so I call this the 80-20 rule. That means in 80% of, if you use a drug most of the time in norepinephrine, 80% of the patient is just this one drug you can treat. Of course, there'll be some outliers, and there you have to give a more personalized strategy. But overall norepinephrine will help to tackle the hypovolemia, will help to tackle the venous return, and help to tackle the low blood pressure and provide very minor inotropy as well. Next. So brief pitfalls and pearls. We often overdose catecholamines in septic shock. And look at the title of this paper. It's a Jekyll and Hyde conundrum. So the Jekyll and Hyde was same person who had a very good face in the daytime and a bad monster at night. So the same catecholamines that saves your patient can actually cause refractory shock and lead to bad outcomes. So it's all in the dose. So you give multiple drugs at high doses that can cause a lot of myocardial ischemia. Next. Use the lowest, lower your target sometimes, as long as the diastolic BP is okay. Have lower targets unless unless you have a CNS condition. Remember that catecholamines foster a vicious cycle of adrenergic stimulation and organ dysfunction, not just a heart. And in most children, we've had very good success with 0.05 to 0.1. Whenever a child is 0.15, everyone is jumping. Why such high dose? Why such high dose? And everyone like trying to look at, what is being missed or something else that can be adjusted to bring down the dose of catecholamine. So this is a dose that works well and has least toxicity in most patients. Next. So with norepinephrine, so this is a nice thing during transport and emergency room if you don't have an echo. You give fluid, give norepi, and if you're monitoring the pulse, one child goes very well, another child's pulses disappear. If the pulses disappear, tachycardia is worse, simply add on an inotrope, such as idobutamine or epinephrine. So when the pulses disappear with norepinephrine, it's really unmasking the myocardial dysfunction. And it's just a clue, it's just a nudge, it's a trigger that the child needs an inotrope as well. Next. So remember that milrinone is not at all a good idea in the initial 24 hours. Catecholamines have half-lives of 1 to 2 minutes. Milrinone is 1.5 hours. So it's a rapidly evolving cardiovascular pathology. And there's a lot of vasodilatation going on. Milrinone potentiates this, can worsen low blood pressure. And what I hate about milrinone, I love milrinone, but not in the first day of septic shock, because that low vascular tone lasts very long and sometimes is very refractory. Next. So basically earlier, 10, 15 years back, it was rush, rapid goals and early goal directed, everything in 1 hour normalized. So now it's everything, the whole world is coming round, the clock goes round and round. So now the mantra is less is more, make haste slowly, act slow, it's less anatropes, less pressors. Next. So I think that's over. That's my last slide. Thank you very much for this session. That next one, I think there's one more. Yeah. Okay.
Thank you, ma'am.
Thanks very much to Dinesh. Let me first thank Dinesh. She was completely, I think you can get a chance to log off at any time. And thank you for helping me with this.
It's a pleasure.
Thank you, ma'am. It was a wonderful lecture. And as you correctly said, ma'am, from the days of early goal-directed therapy, that EGDT, where we used to put in 2 white bore needles and keep on pushing and pulling the fluids to the tune of 200 ml and all. And now we have learned, I think, everything have become more of permissive thing, like permissive hypocapnia, permissive hypoxia, maybe permissive shock, less. I think the more we do, the more problem we are creating. I think slowly we are learning to undo what we have been doing all this time.
True.
And I think one of the very good point that you have given to especially the practicing pediatricians who are working in the peripheries, that you don't require a big paraphernalia, big instruments, big technology to treat your shock. You need your common sense and probably the presence at the bedside, as you correctly said, the urine output, which is a poor man's CVP. Looking at that and looking at the pulse pressure, looking at the volume of the pulses is going to help them to direct their and titrate the inotropy, at least initial part. Maybe at later part, they might require a little bit more tertiary level care. So it was a wonderful talk, ma'am. And I think one point just wanted to get your comments for the other people is that they keep on still talking a lot about your warm shock and the cold shock, and you have done a lot of work on that, ma'am, where still the people think if it is a cold shock, give adrenaline, and if it's a warm shock, give norepi and keep on giving fluids. So can you just 2 minutes you highlight that point, ma'am, about that?
Yeah. So Anjal, yeah, thanks for bringing out that point. So if you look at the ACCM guidelines, which is the American College of Critical Care Medicine, Joe Costello. So the famous, I think in India, we follow that guideline more than Costello's unit also. So, because, yeah, so even in exam, they said like fluids and then warm shock, cold shock. So sometimes these children like to cheat us a bit. They try to keep us on our toes and mix things up. Children with cold shock, we've shown very clearly that 2/3 of children with cold shock, maybe every time you have a patient with cold shock and you're giving fluid, just watch that diastolic BP, watch the pulse pressure. So normally in older children, it's about 40, the pulse pressure. So you can see that it's wide, diastolic blood pressure is low, but still they're cold. So there they need a pressor. If it's a wide pulse pressure, that means it's vasodilatory shock, is redistributed and fluids in the wrong place. They actually need a pressor, both for venous return and for blood pressure. But the common thing is to give them dobutamine or epinephrine, which is not a bad thing, but it takes a very long time for the shock to get better. Adrenaline causes a lot of tachycardia, increases lactates. So it kind of confuses the whole picture. So I mean, if you look at the latest surviving sepsis, they've said very clearly cold and warm shock is out. You can decide either epinephrine or norepinephrine based on your unit policy. Thank you for reminding me to speak on that.
Thank you, ma'am. Thanks a lot. And I think there's no questions as such right now in the chat box, ma'am. So
yeah.
Thanks a lot for your time. And it was a pleasure listening to you, ma'am. It was an honor to have you in CME. I'll move on to the next speaker now. She's Dr. Mahati Reddy. Now, thank you, Dr. Reddy, for joining us from US. She's a board certified pediatrician from Jacobi Medical Center, Albert Einstein College of Medicine from New York. And then she has done her fellowship in pediatric emergency medicine from Children's Healthcare, Atlanta Emory University. And right now she's an attending physician and assistant professor at New York University, Langone and Willoughby Hospital. And it's a big wow for me to know that she's also right now training to become a yoga teacher. So a great lateral interest, Dr. Mahati, and we'll be listening to her in next 20 minutes about her talk on systemic approach to pediatric trauma. And as Dr. Bhaskar was saying initially, that during the pandemic time, she has done a fantastic work on a lot of pediatric transport and transporting the sick children. So over to you, Dr. Mahati, for your talk on systemic approach to pediatric trauma.
Oh. Can you hear me? Can everyone hear me? Okay, hi. Such a pleasure to be here. I'm quite intimidated by the prior speakers, actually. And it was wonderful to hear everyone speaking. I think I have a slight disadvantage because I haven't actually worked in India, so I don't know what the capacities of your trauma centers are and things like that. So I'm going to speak from my experience. So, you know, hopefully you guys will enjoy it. Let me just pull up my screen. All right, can everyone see it?
Yes, ma'am. Yeah, we can see it.
Wonderful. Okay, So I'm talking about pediatric trauma mainly from the ER perspective. So getting in fresh trauma and how to deal with it in the ER. Basically, we're taking a look at a case, a 5-year-old boy who's fallen from a 2-story building. All you know about him right now is that he's lethargic and that he has difficulty breathing. All right. So typically, even before the trauma comes, you have, in an ideal world, your case is going to start before the patient arrives. So you can do a lot to prepare for this patient. So in terms of a trauma room, there are many things that it needs to have. You need to have your equipment and medications in a trauma room. Ideally, the trauma room is going to have a good temperature and not be too cold. You'll have your monitors, you'll have airway equipment, so your intubation equipment of different sizes, your bag mask, your non-rebreather, your chest tubes, as well as large needles in case you need to decompress, and as well as even larger needles in case you need to decompress a pericardial effusion. You want to have your IV equipment. IOs are basically the most important thing in an ER, especially in a trauma setting, because very frequently they've already come in, clamped down after a lot of hemorrhage. You want to have your fluids, preferably something warm, and you want to have blood that's pretty readily available. PRBCs, FFP, platelets. A pressure bag is very useful to have as well, and if not, somebody who can at least squeeze the bag to get rapid infusion going. Warming equipment, so bear huggers, anything really to kind of get the patient a little bit warmer. And your medications. I always think it's a great idea to have something like a Broslow tape, which basically a lot of times your patients will come in unconscious, or you won't have a way to weigh them quickly. A Broslow tape is just a large tape that you lay at the bed in front of the child, and according to the weight, according to the length, it approximates what the weight is, and frequently it'll just give you the dosages of medications right then and there. So epinephrine, TXA, norepi, phenylephrine, pain medications, intubation meds, those are all pretty important things to have. An ABG as well is an important thing to have on hand. An ultrasound, if you can have it in the trauma room, is excellent because you want to be able to do your EFAST. I'm not sure if FAST is a regular practice, but for trauma, it's pretty essential. So FAST is basically a focused assessment sonographically of trauma. So while your patient is coming in, you want to assemble your team. In an ideal world, you would want to have a team lead, one person who's doing airway, another person who is assessing the rest of the body and doing a FAST, 1 or 2 nurses to get your IV access, to drop your medications, things like that. And then if you're in a trauma center, having a trauma surgeon, anesthesiologist, and everything like that. But at the very least, if you are in a small facility getting a trauma, having a team lead, you can combine your team lead with an airway person, having 1 more clinician to look at the rest of the body, and then having a nurse should be okay. So trauma is important to deal with quickly. Very frequently when patients come in, they already have some degree of acidosis and some degree of hemorrhage or blood loss. So already coming in, they're going to have, as I said, metabolic acidosis. The hemorrhage is going to predispose them to coagulopathy and hypothermia. You're having decreased tissue perfusion, which is already going to halt your coagulation cascade. Hypothermia is also going to cause less perfusion of your tissues, leading to extra acidosis. All this is going to basically decrease your myocardial performance, and all these together are known as the trauma triad of death, things that you want to avoid. So patients that are coming in with they're already, and patients that are coming in with trauma, about 25% of them are already thought to have some form of coagulopathy. So reversing it is, or not worsening it at least, is important. This comes into play, especially when we're talking about what fluids to infuse during trauma, because you don't want to extra dilute them if they've already had significant hemorrhage, because you're going to worsen your coagulopathy and increase their chance of mortality. So in the US, we have different levels for trauma, and depending on that, it is dependent on where they go and whether or not trauma surgery sees them immediately or a little bit later, what you need to transfer out, so on and so forth. So your level 1 traumas are patients that come in already intubated, or if they have severe respiratory distress, respiratory arrest, or signs of shock, patients who are already receiving blood, patients with significantly low GCS, or in terms of visible trauma, if they have any kind of trauma to the head, neck, penetrating trauma to the head, neck, torso, groin, extremities, if they have flail chest, crush injuries, depressed or open skull fractures, partial amputations. Level 2 are going to be patients who have suspected spine trauma, bilateral femur fractures, pelvis fractures, maxillofacial injuries, or significant pedestrian strokes. In addition, any kind of really significant burns or inhalational injuries might be considered level 2. The rest of the patients would be considered trauma consult if they had a very significant type of injury, but otherwise are looking more or less okay. So this patient has arrived to the ER, is appearing lethargic and groaning, has obvious difficulty breathing, and is bleeding from the scalp. Vitals are 36 degrees Celsius, pulse is 140, BP is 80/50, and respiratory rate is 40, OSAT is 86%. So according to what we said, this patient has a trauma level 1 criteria and is already pretty significant. So when you're looking at this, trauma is best dealt with very systematically and very algorithmically. You basically, if you have polytrauma, there's things that you can miss pretty easily. So going through, you want to go through a primary survey, a secondary survey, and a tertiary survey, and this is through ATLS. So in the primary survey, you're going to assess each thing according to the order that it's written in. So catastrophic breathing, airway, breathing, circulation, disability, and exposure. And if you find anything that's off at any point of these times, you want to stop and intervene at that point in time. So for example, for catastrophic bleeding, if you're seeing, for example, with this child, you're seeing significant bleeding from the scalp. Before you go any further, you need to stop and address that, all right? So apply Durin if it's anywhere on the trunk, or for example, for this case, for the scalp, you want to apply direct compression or quickly staple it up. If it's at the limbs, you want to apply tourniquet. Again, you want to minimize blood loss, and then, thereby reducing the whole trauma triad of death cascade. So after catastrophic bleeding, you have airway. All right, so a quick and easy assessment of when a person comes in. If a person can speak, then they're pretty much okay. If the person has stridor, bloody secretions, that's pretty concerning. At this point in time, also, you want to go ahead and immobilize the C-spine and also quickly examine the neck. If you open your airway, you can do jaw thrust, but you have to keep your neck at midline. Examine their oral pharynx. You want to suction if necessary. Also see if there's any significant nasal bleeding, and because that can go posteriorly as well and cause airway impingement. And then also, if you have a GCS of 8, if they're coming in really bad, this is a point where you have to consider intubating quickly. So after airway, you have breathing. So this is a quick assessment of breathing. You don't want to sit there for hours and hours and do your multiple quadrants and everything like that. Quick assessment. You are going to go back during your secondary survey and do a full, better assessment of your chest. So if you have apnea or poor effort, this is your clue to go ahead and think about quick intubation. At this point in time as well, you're going to look for signs of tension pneumothorax, so your absent breath sounds, distended neck veins, tracheal deviation, hypotension. And if you see this at this point in time, you have to intervene immediately. Decompress, so you put a large bore needle in your second intercostal space, mid-clavicular line, followed by likely a chest tube at the 4th to 6th intercostal space, anterior axillary line. At the breathing point as well, airway and breathing, you probably probably want to go ahead and put a non-rebreather in the patient, or some form of high oxygen. Non-rebreather is ideal, but if you have to intubate, obviously you have to take that off. So, having a nasal cannula while you're doing it is going to be helpful as well. If you're concerned of a pneumothorax and you're going to intubate the child, you should consider going ahead and putting a chest tube first, because that can worsen the pneumothorax. So if you see on the left, you see a significant pneumothorax, large pneumothorax with a deviated trachea. On the right, you are going to see what your FAST findings are going to be, so your ultrasound findings. So on the left part of the ultrasound section, you see kind of a little granular line, and that's basically what your normal pleura looks like. That's normal pleural sliding. So it looks like a beach, waves on a beach. The one next to it is basically called a barcode sign, and this is a sign of a pneumothorax. So very solid lines, no granularity. It looks pretty uniform. There's no pleural sliding in that one. You're going to go on to your circulation part. So this also is going to be quick. Basically your whole primary survey needs to be done in like a minute. So you're going to be checking your heart rate, your central and peripheral pulses, your cap refill, your blood pressure. You listen to your heart again quickly. Basically, is it beating? Are there any signs of pericardial tamponade? If you see that you have abnormal BP, central peripheral pulses are abnormal, cap refill is abnormal, but you're not seeing any obvious signs of external bleeding, you need to also check the body for any kind of bruising, like abdominal bruising, chest bruising, again, really quickly, as well as, and if you don't see it on any part of that, then you need to also consider that you're having a lot of bleeding into the pelvis potentially. So if you have any questions about that, then you should go ahead and just find the pelvis. You can have a lot of bleeding into the pelvis, and it could cause a significant amount of cardiovascular compromise. So if you're seeing obvious bleeding, let me go back to it. If you're seeing cardiovascular compromise, you should consider administering normal saline, or you should administer normal saline, preferably warm and up to 40 mLs per kg and pretty rapidly. The caveat to this is if you're seeing significant bleeding, then you want to administer a little bit less normal saline, maybe 20 mLs per kg rapidly, and that's while you're basically trying to get blood. You don't want to dilute. You don't want to dilute because again, it's going to worsen any possible coagulopathy that you might be having. So let's say you administer anywhere from 20 to 40 mLs of normal saline quickly. You want to go ahead and get that red blood cells into this person. You want to improve their oxygen carrying capacity. You want to expand their volume without causing any kind of dilution. So PRBCs, you want to get like 10 to 20 mLs per kilogram, and you want to do that also pretty quickly, and you can consider repeating it. If you're not seeing any change with this, you should go ahead and consider massive transfusion protocol, which is basically your PRBCs, your FFP, and platelets. There's been a lot of debate over what is the ideal massive transfusion protocol, but we basically do 2 to 2 to 1, 2 PRBCs to 2 FFP to 1 platelet. And you should consider TXA as well if your injury is under 3 hours. So going back, since we talked about FAST, FAST has different components, excuse me. So we just looked at the lung component of FAST before. This is basically looking at your other parts of your FAST. So number one, the first view is going to be your pericardial view or your subxiphoid view. And this essentially is looking for any kind of pericardial effusion and whether or not the heart is beating effectively. So on your left, you see your liver and your pericardium, no effusion. And on your right, you see that there is a pericardial effusion and you have some right ventricular compression. Can you see that up? And after that, I go to the right upper quadrant looking for Morrison's pouch. So this is going to look at the interface between your lungs, your liver, and your kidney. So any kind of right pleural effusion or liver laceration or right kidney laceration could create fluid in this area. So on the left side, you see what a normal fast looks like on the right upper quadrant. And on the right side, you see free fluid in Morison's pouch. Then you go to the left upper quadrant. Okay, this is looking at the interface between the spleen, kidney, and the diaphragm. So again, on the left, a normal fast of the left upper quadrant. And on the right, you see free fluid above the spleen. This is signaling a splenic laceration. And then finally, you're going to look at your bladder view. And this is basically looking for any free fluid in the pelvis. So Douglas pouch, you see some free fluid over there. Moving on, finally, to disability. So disability is essentially looking at your neurological status. So in this point in time, you're going to look at your GCS. You're also looking quickly for signs of like cerebral herniation or neurogenic shock. And in assessing disability, you shouldn't forget to roll the patient to check the spine, cervical spine, and the rest of the spine. So in terms of disability, if you have anything at GCS 8 or less, you automatically intubate. You also should consider elevating the head of the bed to 30 degrees, helps decrease cerebral pressure, intracranial pressure, excuse me, and to keep your end tidal CO2 at 35 to 40. You should check for signs of impending cerebral herniation, so any kind of unilaterally dilated pupils or Cushing's triad, so bradycardia, hypertension, any kind of Chine-Stokes respiration. If you see this, you should hyperventilate briefly. You still want your end tidal CO2 to be anywhere from 30 to 35, and you should go ahead and administer your hypertonic saline or mannitol. So hypertonic saline at 5 mL per kg per dose over 10 minutes, or your mannitol at 1 gram per kg per dose over 15 minutes. And these are all just temporizing measures until you can get them to neurosurgery for a drain. And you want to check for signs of neurogenic shock. So neurogenic shock signs are going to be bradycardia and hypotension, as well as abnormal tonus strength. And if you have the hypotension associated with neurogenic shock, then norepinephrine is going to be your vasopressor of choice. And if that's not working, and you can titrate to effect as well, or you should titrate to effect as well. And if that's not working, your second drug of choice is going to be phenylephrine. After that exposure, you want to go ahead and remove your clothing. Depending on what the trauma is, the clothing can be wet, worsening your hypothermia, or it can contain toxic materials. And then you should cover the patient immediately with warm blankets or a bear hugger or whatever to keep them warm. So with this patient, primary survey basically revealed bleeding from the scalp. His airway was intact, but he was groaning. His breathing was labored with absent breath sounds on the right with distended neck veins. His circulation was notable for tachycardia, no distant heart sounds, intact but thready central pulses, and poor capillary refill. In terms of disability, his GCS was 6. He had intact pupils and was withdrawing to pain at all extremities. With his exposure, his clothing was removed. So you have the primary survey. Again, at each point in time, you want to go ahead and intervene. So immediately you saw the bleeding at the scalp. You placed pressure on the scalp wound, got it quickly stapled. You placed the kid on non-rebreather oxygen. You noticed absent breath sounds and signs of attention pneumothorax. So you automatically decided to needle decompress him and started preparing for a chest tube, placed the chest tube, intubated the child. And then you're seeing signs of significant hemorrhage. So you go ahead and start with a smaller amount of normal saline while you're getting the PRBCs ready, and go ahead and call for a massive transfusion protocol. After all this is done, the heart rate has improved to 120, BP was 90/60, and oxygen saturation was 98%. Your trauma surgery was consulted. And then while you're doing all this, you've moved on to your secondary survey. So primary survey is for rapid stabilization. Your secondary survey is to see what your other injuries are. As you mentioned, you have a trauma, you can have polytrauma, and you don't want to miss anything. So secondary survey is going to be a head to toe assessment, starting at the head. So with your head, basically you are going to start by palpating your scalp. All right, see, for this child, he had a significant scalp laceration, but you also want to see for any kind of bogginess. Bogginess, could indicate hematoma, but it can also indicate significant open fracture of the skull. The other things you want to see are basically for signs of a basilar skull fracture. So if you see in the bottom left, you're going to see a battle sign, which is basically ecchymosis behind the ear. You can see otorrhea, you can see hemotympanum, or you could see periorbital ecchymosis. These are the classic triads of a basilar skull fracture. In addition, you want to look for any kind of signs of mid-face fracture. And then at the bottom, you see what's basically a septal hematoma. Septal hematomas make you concerned for mid-face fractures as well. Septal hematomas should be drained, otherwise they're going to cause significant septal injury. If you see any of these signs, then you have to consider a head CT or a head and face CT. Then you're going to go on to the neck. All right, you probably have a cervical collar at this point in time. You want to open the cervical collar as well, recheck the C-spine for any signs of C-spine fracture. And then you want to look at the neck for signs of penetrating trauma or expanding hematoma, any kind of hemoptysis. Your neck is basically divided into zones in terms of trauma classifications. Your zone 1 is going to be the lowest part. It's your cricoid process to your sternoclavicular notch. And any kind of trauma in this area is going to be potentially involving your trachea, your esophagus, potentially your laryngeal vagus nerves, possibly like the proximal part of your common carotids, vertebral subclavian arteries. Your zone 2 is more than likely your zone 2 is the most likely cause of area where you're going to have trauma. And it's from the angle of the mandible to the cricoid process. This one is going to potentially involve your larynx, pharynx, vagus nerves, your common carotids, your internal, external carotids, your jugular veins. So a lot of vascular trauma in this area. And then your zone 3 is your most cranial part of the injury. And this is from the base of your skull to the angle of the mandible. And this one is going to hit your external carotid, jugular veins, some cranial nerves. Yeah. Next, in your secondary survey, you'll move on to your chest. This part, you're basically going to be doing a better examination of your lungs. You're going to be looking for bruising or crepitus. You're going to be looking for flail chest, which basically you can see an X-ray of flail chest to your right. You're going to have 2 or more ribs broken in more than a couple spots. And this essentially is going to cause paradoxical movement in the section of the rib breakage. You're also going to be concerned about sucking chest wound, which actually, if you see a sucking chest wound, that should be part of your primary survey. Sucking chest wound is involving penetrating injury to the chest. And basically you're having a lot of air going into the space where it should not be. So you have to apply a 3-way dressing for this one. So occlude it with a gauze and tape it on 3 sides. Also, you're going to be looking for your pericardial effusion that you might have missed, something that's not significant, but still there, and as well as cardiac contusions. Then moving on to your abdomen. Over here is a picture of a seatbelt sign. So basically the child has had a good amount of compression with the seatbelt, which has caused injury to his abdomen. Any pain or bruising to the abdomen or flank should be concerning for abdominal trauma, and you should go ahead and get an abdominal CT, even if your FAST is negative. FAST is actually pretty user dependent. So if you're good with ultrasound, it can be pretty accurate. However, it can miss smaller injuries, smaller bleeding. And children as well, it could be a little bit less accurate, not accurate, a little bit less useful than for adults. However, hollow viscous injury can be a little bit more subtle. We've had kids that had small hollow viscous injuries that initially presented with no pain to the abdomen at all, actually sent home and then came back the next day with fever and significant abdominal pain. So discharge instructions, if you're going to send a kid home with trauma, is going to be pretty important for this injury. Next is going to be your pelvic injury. pelvic injuries are usually associated with high energy injuries. As I said, you can lose massive amount of blood into the pelvis. And if you have any concern for pelvic injury, you need to bind quickly. So you see a pelvic binder on the bottom, and it's basically somewhat of a corset kind of thing, and you tighten as much as you can to basically tampen up the space. If you don't have a pelvic binder on hand, you can essentially get a blanket or a sheet and tie it very, very tightly around the pelvis. You also want to look to the genital area, look at blood from the vagina or from the urethral meatus. You can have saddle injuries in this area. If you see any blood from the urethral meatus, you should not catheterize because you can cause worsened urethral injury, excuse me. You want to check your rectal vault as well if there's concern for pelvic injury. And then finally, for your limbs, you want to check for fractures. If you have any kind of obvious displaced fracture, make sure that you're checking for pulses. If you have any loss of pulse, this really would be part of primary survey as well when you're looking at cardiovascular. If you see any loss of pulse, you need to basically reduce the fracture pretty quickly and go ahead and splint as well. Femur fractures actually in children, if they're isolated femur fractures, don't typically lead to hypotension. Right? You can lose blood, but it's a compartment, and more frequently they'll get compartment syndrome, and it'll be somewhat tamponaded by that. You want to check for signs of compartment syndrome as well. If you see open fractures, you should go ahead and give antibiotics and tetanus, and likely they'll need to go to the OR for a washout. Everyone always forgets the axilla. When you're doing a secondary or even a primary survey, you should be looking at an axilla as well. Very frequently, you can have penetrating injuries in that area. So for the secondary survey for this child, there was a boggy scalp to the right head. There was bruising to the chest and abdomen. There was no noted pain to the pelvis, no blood at the urethral meatus or rectal vault, and no obvious deformity to the limbs. A CT of the head, chest, abdomen, pelvis was performed. They were noted to have open fracture of the right parietal skull with subdural hemorrhage, but no midline shift. There was noted to be an improved pneumothorax and a non-displaced fracture, and noted to have a liver laceration. The child was taken to the OR. Neurosurgery basically helped decompress, and then was taken and had repair of the liver laceration, and then was taken to the PICU. This is kind of the end of the ER section. However, in about 24 hours after all these things have been done, after all these interventions have been done, you have to reassess the secondary survey just to make sure you haven't missed anything, potentially smaller even. So that is about it.
Right. Thank you, ma'am. It was very nicely elaborated pediatric trauma lecture that you have taken, and to just fill you in up, in India also now, as a part of pediatric critical care fellowship curriculum, we have EFAST and lung ultrasound as a part of their training program. So all of fellows are well trained in doing the EFAST and the lung ultrasound at the bedside and in the ER. So and the points that you brought out about the abdominal trauma is very important. I think that is something which is a subtle Pandora box, which people don't look at it. So any bruise in the abdominal area and the high intensity impact injury, I think it's very important. We have seen a multiple grade 4, grade splenic and liver lacerations, and the renal lacerations. The children who are coming up and been missed, and they have a devastated outcome. So I think very nicely leaves the presentation, ma'am. Thank you for your presentation. And there was a question, I think this is about the tetanus toxoid that you were mentioning. Somebody has asked in the chat box, does a 19-year-old boy need to be given TT if he's fully immunized up to 15 years of age?
So in trauma setting, it is yes, because it is unlikely. Well, I mean, you can just not trust people that are coming in with trauma, and the devastation is higher. So I would say if you are at all, if it's a high trauma situation, we just give it.
Okay, right. If I just can just bring a point over here, in a setting also, we usually don't give TT now for a trauma in case there's a significant trauma, irrespective of their immunization status. We try to give them the TID cloak because that's going to act faster, and the chances of getting the tetanus is less because the TT is going to take some time for it to act over. So that is what we are doing in case if we get a child with although 19 years actually spill over to the adult side, doesn't come to the pediatrics at all. But anyway, that's all. There's no other question. I thought I'll just ask a question. So what is your unit policy about putting the cervical collar in the child, even if he's awake, when he has a high impact surgery? Do you put it till you clear the C-spine, or you don't use it?
Yeah, we put it till the C-spine is officially cleared until we've done the trauma survey.
All right.
So basically, everyone who comes in for concern for a trauma gets a C-spine until it's officially cleared by us.
All right. So I think there's some more questions for your presentation. The one is by Dr. Neeraj. He's asking, what is the role of steroids in head injury? I think he's talking about a significant head injury.
So this is also debatable. There are some facilities that don't give it. I think the literature on this is unclear, but we tend to give it in our facility.
Okay, all right. Thank you very much, ma'am. And it was a real pleasure listening to you, and hope that we will have a better association so we can keep on having some lectures from you in the near future with the help of Dr. Bhaskar, sir. And thank you for your time. I know it's late in the night there for you. So thank you very much for being with us and being a part of this CME. Thank you. Yeah, thank you. Right, so I'll move on to the last part of this CME today. This is a panel discussion on the pediatric emergencies in the peripheries and the tertiary level. And the moderator for this session is my dear friend, Dr. Satish Khanta. He is the director and CEO of Little Star Children's Hospital. He is a neonatologist as well as pediatric intensivist and pediatric cardiac intensivist, and he has done all his training from Australia. He's been here for past 15 years and he's been doing a fantastic job. And apart from being a very good pediatric intensivist and neonatologist, he's a philanthropist. I know he's doing a lot of work on the children for orphanages and providing the meals for poor children. And he'll be moderating the session today, and the panelists with him today are myself, and along with me we have Dr. Chetan Mundada, who's the lead pediatric consultant and director of pediatric critical care at Yashoda Hospital, Secunderabad. We have Dr. Pritesh Nagar, who's the lead pediatric intensivist at Care Hospitals, Hyderabad. And we have Dr. Parag, who's the pediatric intensivist and the lead consultant pediatric intensivist at KIMS Hospital, KIMS Cuddles Hospital, Hyderabad. So I pass on the mantle to Dr. Satish. He will take you through the next 20 minutes. I know he has a Herculean task to do that. Over to you, Satish. You can share your screen, Satish. Yeah.
So thanks for the lovely introduction, Anjul, as always. At the outset, I actually would love to thank Dr. Bhaskar Garu and Sri Krishna Garu. Bhaskar Garu, actually, he called me almost a month ago and he said, So we need to live up to what we have done last year. That was a fabulous intensive care seminar that we have done, webinar. So this time, the main thing that, he was espousing was how useful it could be to the general pediatrics people. So that's very, very important. So we'll try to keep it very, very interesting to the pediatricians. So on behalf of all the intensive care team and the fraternity, intensive care fraternity, I'd like to thank Dr. Bhaskar Garu for giving us this opportunity. Thank you, Andy. So I'd like to start the proceedings, and we'll try to have a couple of case scenarios, and we'll try to elicit a response from everybody. So I'd love your involvement as well. So let's take it from there. So the first case is going to be taken by Dr. Parag. So he'll talk about the case, but basically what Dr. Suchitra has the kind of presentation that she's given is absolutely fabulous. She's a legend. And the first couple of hours of management of these children with shock, and then once they progress on to persisting shock, how do these kids need to be managed? So it's very, very complementing. So what we have learned until now from what Dr. Suchitra has said, so this is going to be complementing. So let's take it from there. Parag.
So thank you, sir. So she was an 8-year-old. So we'll start with the case, and we will try to focus, as Dr. Satish Ganta said, probably 3 to 6 hours after the initial shock stabilization. So it's an 8-year-old female child, had a fever for 4 days, cough, and rapid breathing since last 2 days. And the child had a severe workup breathing. Outside investigations were not that much of contributory. At presentation, so CRP was 37, WBC count was 2,200, and platelet count was 72,000. These are the only investigation when the child presented to us. At presentation, child had an increased workup breathing. Child was looking drowsy, and the circulation also pale. So definitely life-threatening. Next time. So on secondary assessment, child had a severe workup breathing. You can see saturations of 84 in a room air and 40%, around 92%. Circulation, child was tachycardic, had a decompensated shock. Child had a drowsiness, though there was no focal neurological deficit. Child was febrile, and airway was open and unstable. Next slide. So as Sujita Ranjit ma'am has pointed out, the child was started on face mask oxygen and initiated rapidly, quickly to heated high flow nasal cannula, given nebulization. Appropriate antibiotics were started. The line was in place, 2 peripheral line, but arterial line. Initial fluid bolus was given 40 ml per kilo. There was some marginal response, and subsequently, as Madam said, within 3 hours, inotrops was started. Over the next 4 to 6 hours, there was a marginal improvement in the blood pressures and heart rate. There was a borderline blood pressure, but there was a worsening of the clinical respiratory status. The viral PCR, which was sent, came in 4 hours positive for influenza, and the cultures we had at the end of 24 hours were negative. If you see investigations, the child had a thrombocytopenia, leukocytosis. There was a DIC features in the form of thrombocytopenia and high INR. Acute kidney injury was also there. And there was a transaminitis. So child had multi-organ dysfunction in this case.
Yeah, I mean, that was a typical kind of a sick child. So this child was sort of deteriorating quite rapidly, both in terms of the respiratory as well as the cardiac status as well. So Anjul, if I may ask you, what are the clinical and investigative indications, where we need to consider escalating respiratory support in these kind of children, where there is shock? That is number one. The second question I'd like to ask you is, there are scenarios where you have children in shock, but there's no worsening or respiratory deterioration. So that is what the second consideration. And then certainly what are the kind of the respiratory modalities? Anjul.
Yeah. Right. So I'd like to be very brief. I think Dr. Suchitra ma'am has already briefed a little bit about that. So if you look at the clinical indicators for escalating your respiratory support, I think it is your tachypnea, tachycardia, hypoxia. These are very apparent things. And I think anywhere where the shock requires more than 2 fluid boluses, or the child has come initially in a stage of a very severe shock, or respiratory embarrassment in the form of the child is hypoxic or cyanosed, these are the children who definitely require your respiratory support. Initially, to start with 100% oxygen, the best way of giving 100% oxygen will be a non-rebreathing mask. And in case if the child doesn't improve with that, then you can go on your HFNC or your NIV ventilation. If you look at the investigation modalities, probably looking at the ABGs where there's a worsening acidosis or the lactate being going high is going to help. Remember, PCO2, which starts rising up, is a very late sign. Initially, when the child is in shock, he'll be tachypneic, there will be hypocarbia. But in case if you get a normal CO2 in a case of a child with a shock, then that again becomes an indication of escalating the respiratory support. Coming to the second part of your question, the different modalities of respiratory support, as Parag has already told, initially we start with 100% oxygen. We can go up on a heated humidifier, HFNC. In case the child is not doing well, then we go on NIV. Now, these are the non-invasive modes of ventilator. And of course, we go on the invasive mode of the ventilators. I think we'll be talking that a little later part. But remember, the respiratory and the cardiac supports, they go hand in hand. It doesn't matter if the child is having only a shock with no respiratory distress that you don't require respiratory support. Probably the respiratory support is going to bring down the work of breathing, and that actually increases or improves the chances of the shock getting reverted back to normal. And the last part is, in case if the child is having an altered sensorium, then do not give your non-invasive ventilation. With a severe shock, altered sensorium, this child will definitely require a straightaway and invasive ventilatory respiratory support.
Thank you so much, Anjul. You've made it look so simple. So this is a very strong point that people, the pediatricians, need to consider. Okay, because many a times we get calls from the periphery saying that yes, the child is in shock, but the child is breathing okay, could we wait? So if there is severe shock, uncompensated shock, please understand that if the child is ventilated, at least a good 20% of the cardiac output is utilized for all the other vital organs. So there's redistribution happening. So it just eases it out. So that's the take home point. So yeah, Parag.
Yeah. So subsequently, this child, as I told, there was some kind of a marginal blood pressure improvement, but you can see the inotropes, adrenaline, noradrenaline doses are increasing. Next slide, sir. And the blood pressures are okay, but intermittent drop of the blood pressures are there, and you are on invasive, non-invasive, and subsequently the child was intubated, put on PRVC mode, and we're on 100% oxygen. So this child was deteriorating rapidly, both hemodynamically as well as respiratory. And you can see in these blood gases, there is a metabolic acidosis and the lactate is increasing. Means this child is on epinephrine and norepinephrine marginal doses. And you can see there is an improvement in the blood pressure a little bit, like you are able to maintain the normotensive blood pressure, but still metabolic acidosis is worsening. Lactate is worsening.
Yeah. Yeah, that's a very, very strong point. If you remember, Anjul, Dr. Suchitra was alluding on this point very nicely. So there is persistent acidemia as well. Yes. Parag?
Previous.
Parag?
Yeah.
Yeah. So we see a lot of sick children, Anjul, here. And as she said, acidemia is very, very important. So what do you think, what are the sort of the points that you need to keep in mind where, children are sick and acidemic, that blood pressure is close to normal with a little bit of inotropy. So what are the things that you need to keep in mind, Anjul?
Right. So I think the first important point that we should always remember is that shock is not equivalent to low BP. The shock is a state where the metabolic demands of the body are not being met, and this can occur with a normal blood pressure also. So let us not look at just the blood pressure and say the blood pressure is fine, then we are okay. No, probably looking at the other microcirculatory parameters, as Dr. Suchitra was talking there about the macrocirculatory, where your pulses will be low and your contractility of the heart will be less. But more important, looking at the microcirculatory levels, because that is where your goal of treatment remains there. One of the things that she talked about, which is easy to look at the bedside, is your capillary refill time, then is your urinary output. The other thing, as Parag said, is your rising lactate level, or if you can do your mixed venous oxygen saturation, you can look at that. You can look at your echocardiography. So those things are going to actually help you in deciding how is the child doing. And I think a proper documentation, and I think I should compliment Dr. Parag for an excellent documentation, what he was showing there in the case sheet. Actually, if you have a documentation like this, it becomes very easy for the intensivist or any physician to decide on the bedside how the child is doing. So I think the most important thing is, do not try to equate your blood pressure with your shock, and look at your microcirculatory parameters like your capillary refill time, your urine output, and looking at the acidosis and the lactate part as well.
Thank you so much, Anjul. You recap the whole thing again. Thank you so much.
Sir, one thing I wanted to tell, a lot of kids, like a lot of times what we do in this kind of a situation, we start dobutamine and all those things, but let it sure that dobutamine doesn't help with microcirculation. So it doesn't help. So don't start this medication unnecessarily if you feel. Yes. So next slide. So you can see progress over the 1 to 2 days kind of a timing. We are on very high ventilatory settings. From conventional, we went into high frequency oscillatory ventilation with very high pressure. So respiration is deteriorating. With shock, we are on epinephrine, norepinephrine, and vasopressin. So it's really troubling us. Still, we are tachycardic, blood pressures are hypotensive, and the multi-organ dysfunction is worsening. So as Dr. Anjul said, this child is going from cardiovascular failure with multi-organ dysfunction. And you can see blood pressures, they are almost hypotensive with the high tons of this support. We are actually on very high frequency oscillatory ventilatory settings. Still, we are hypotensive. Next slide, sir. And you can see the support. So you are almost on 4 ml of epinephrine, norepinephrine, and you can see vasopressin here, which is started. We went up to the maximum doses. So stiff support, not maintaining oxygenation, not maintaining blood pressures.
Yes. So, I mean, that's the kind of critical or sick scenarios that we tend to see in the ICU, Anjul. So here we are witnessing a rapidly progressive shock, not responding as he was just explaining, and he was clinically deteriorating. So here, Anjul, could you just, for the benefit of everybody, could you just clearly explain what's refractory shock and what's catecholamine resistant shock, please?
Right. Yeah, I think this child is any pediatric intensivist nightmare, where nothing helps actually. So if you're looking at the refractory shock, if you look at the definition, refractory shock is an hypotension which is associated with an end organ damage. So it can be either your transaminitis, your AKI, or your urine output being low, and associated with the high dose of your vasopressor supports or vasoactivation supports. In adults, it is being defined as more than 0.5 microgram per kilo per minute of your norepinephrine or any other inotropes. And if you look over here, he's on adrenaline, NORAD, and vasopressin. So this is clearly a refractory shock. And when you are talking about the catecholamine resistant shock, now this is the condition where the child who's on moderate doses of epinephrine and norepinephrine, the steroids being tried, but the shock is not getting controlled. This is your catecholamine resistant shock. Now, these are the children who are the sickest of the children, and probably you have to now think about beyond the vasopressors or vasoactive agents. You have to think about what else you will be doing in these children and looking at the other parameters as well.
Yeah, very true. So, so we all agree that this child is sick, and, it's getting to a level where there's a lot of escalation of support being done. So how important it is here, how pertinent it is to monitor these children, and what are the tools you'd like to have at your bedside, Anjul?
Yeah, I think it's a very important question. And when we were doing the fellowship under Sujitra, so she used to say that the most important tool is a pediatrician standing at the bedside. I think nothing can beat that tool. But when we come to the monitoring, I think the monitoring doesn't have to be very extensively high-end. Definitely in a case like this, we do definitely require. But most importantly, we require to check an accurate blood pressure it's always preferable to have an arterial line and looking at the invasive arterial monitoring over here. If you have a facility to look at the echo, because you require to look at the contractility of the heart, we require to get an ultrasound of the abdomen done to look at the fluid status, look at the urine output, if possible, look at the CVP, although one value of the CVP is not going to help, but the serial CVP readings, depending on giving the fluids and inotropes, is going to actually help. Cardiac contractility is going to make a lot of difference, because that is going to tell us what type of inotropes we'll be using, and vasoactive agent, sorry. And in case if we have a facility of doing the other high-end vasoactive monitoring or invasive monitoring to look at the SVRI, that's going to actually help in deciding. Similarly, looking at the mixed venous oxygen saturation is going to actually help us in deciding about titrating the inotropes.
So yeah, absolutely. All these things are needed, but nothing like having a bedside echo, isn't it, Dr. Anjul? So here, as we all know, it's an extremely useful tool in assessing the hemodynamics. And it's not only about assessing, it helps us to serially monitor the hemodynamics so that we could, titrate the inotropes. So in this case of yours, Parag, so would you let us know how echo was helpful in this child?
Yeah. So in this child, when we got an echo done, again, what Dr. Anjul said is very important to see. So you can see the IVC here. IVC is quite full. And what happens normally in a breathing child, what you see some collapsibility of this. This is completely full throughout the breathing. And you have to make it sure that when you are assessing this IVC, that what are the pressures, how much you are ventilating the child, what is happening in your tummy, there is a ascites, or all those things has to be taken care of. So for this child, the IVC was completely kind of a full. Child was on the high ventilatory settings, but this is more than what usually we see in this patient with ventilated. So IVC was completely full here. And we got an echo done to see. So when we check for echo, as everybody knows, kind of a new stethoscope in the ICU, we check for the IVC, we check for the fullness of the, so this is an LA. And then we have a ventricle, and you can see in the next film, so that the interventricular septum is barely contracting. So the child had a completely severe LV dysfunction. It's almost very low contractility, which is happening inside the myocardium. So this child had a complete myocardial left ventricular dysfunction. And on top of that, IVC is full and you're on tons of support. So this child is progressing into a phase, as Dr. Anjul said, that nothing is helping here. You can see barely contract. This is an interventricular septum. If you are able to see my pointer, the interventricular septum is barely contracting. So it's kind of almost going into the stunned myocardium, where most likely the myocardium is not getting perfused.
Yes. So
this child had a severe ventricular dysfunction and IVC was things, and we are on very high inotropic support, as we said, that the respiratory is worsening, MODS is worsening, and you have a hypotension. So one thing what Sanju said about the refractory, I would say, shock, the one thing which is very, very important is refractory shocks. Almost 10% of the pediatric patients presented with refractory shock, and mortality is very high, 50% die in spite of all the modalities. And the most important thing is they have a very high levels of inducible nitric oxide in the body. And that's why most of these are vasodilatory. That's one thing. Second thing, they have a down regulation of catecholamines, down regulation of catecholamine receptors, vitamin C receptors, B1 receptors, all those things go down. So it's become very difficult to treat this patient with inotropes and fluids. So they might require the other additional modalities also. Next slide, sir.
Yes. So the child is deteriorating, isn't it? And,
yes.
As you said, you need additional modalities, you're doing everything, you're titrating your inotropes. So how important it is to choose your inotropes? There was a lot of talk, there was a lot of discussion happening over the last 1 to 2 hours. So would you be brief, and at the same time, would you explain well, so that, the pediatricians practicing in the periphery would have a nice view about how they would choose the inotropes?
So as everybody has pointed, including Suchitra ma'am, there is no march of inotropes. It's a physiology specific inotropes, and only 2 inotropes, if you keep in the mind, probably you will be able to save most of these kids, epinephrine and norepinephrine. So what is shock? Shock is a balance between VO2 and DO2. So basically utilization and delivery. And delivery depends upon cardiac output. which itself depends upon stroke volume and heart rate. So we know that heart rate has a limited ability to improve the blood pressure. So this is not a good tool to actually take care of their health to improve the blood pressure. Stroke volume, we have a preload, as sir has told Dr. Anjul, how much of volume is available into RA. Afterload, against which we are actually, the myocardium is functioning very hard, and myocardial contractility itself. Ultimately, what we are able to change is preload by giving a fluid volume. Afterload, again, very unlikely we actually require this unless and otherwise there is a prominent cardiogenic shock. And contractility is another thing. So we play with two things. We play with systemic vascular resistance and contractility. That means we increase the SVR, we constrict the blood vessels so that we are actually having a blood pressure, or we increase the force by which the myocardium is constricting. So everything depends upon DO2, BO2. So depending upon that, we can choose your inotropes. Next slide, sir. So very simply, most of the time, as Madam has said, there is no warm shock or cold shock, because a lot of us, we know about this terminology. That's why I use this. So we see in this phase, what happened is the child comes with tachycardia. There is a white pulse pressure. And in this kind of a situation, actually the myocardium is working at the higher level. It's like you are riding on the fogging horse. So it's constricting very rapidly. So in this kind of a situation, the myocardial contractility is good. So you don't need any medication which will increase the contractility, but you will increase because the vessels are dilated. As Madam said, there is a venous capacitance, vessels are dilated. You need medication to constrict it. So most of the time, norepinephrine would be helpful. Vasopressin, again, in the ICU, we use very low dose because they say it's better than norepinephrine, but most of the situation, norepinephrine is the. Yes. If you don't take care of these kids in this phase, what happens is ultimately the myocardium will start actually showing the features of low contractility, and the SVR will also fall because this is already low and now the myocardium is also low. This is a situation which comes to most of the ICU when they are really in a bad situation. So what we have to improve this, we have to increase. So we need inotropy, and SVR is low. So we need to constrict this vessel a little bit. So what is here? Inoconstrictor, basically inotropy and constrictor. So we have adrenaline and dopamine. And the third scenario, which we usually see in cardiogenic shock, what happens is the myocardium is not functioning well and your SVR is little bit higher, or you are maintaining the normal blood pressure. So you start inodilator, where it's helping the myocardium and it's relaxing the blood vessels. Okay. So in this patient, the shock was persistent, very high. There is a metabolic acidosis, organ dysfunction, ejection fraction was just 20%, and still hypotensive and tachycardic. Next slide, sir. And you can see the child was completely hypoxic over the next 2 days. Lactate was rising, and you have stiff inotropic support down, and we are on high escalating respiratory support also. So this is going into the complete cardiorespiratory failure. As we said, there is a complete hypotension here with the stiff inotropic support and high frequency oscillatory ventilatory setting. Next slide, sir. Same thing here, adrenaline 0.4, 0.4, vasopressin very high.
So pretty much a very tough scenario, isn't it, Parag? So child is worsening despite giving the best of everything. You've got all the respiratory support on, you've got the cardiovascular support, you've been titrating that, you're getting your 2D echoes and your blood gases. So, at the end, what are the other things, what are the other modalities that you have in mind, or what are the things that we could do to get this child better?
So this is kind of a hitting the wall. Like, we know that we can't get anything much out of the heart as well as respiratory system. So here, what we have to unload the heart as well as lungs so that we can buy some time for the heart and lung to improve. We expect that once the pathophysiology under control or pathology under control, things will settle down. So only option left in this kind of a scenario when the heart and lungs are not functioning properly is going on the ECMO. And most of this kind of a setting, when you are having such a bad shock, we go on a veno-arterial ECMO. That means we pull out the blood from the veins, bigger veins. Most of the time, it's actually right IJ and right carotid. So we pull out the blood from the right IJ and give it through the right carotid to the arch of aorta. So this child actually went on a VA ECMO, and we were able to titrate all those things over the time.
Yes. Yeah, thank you very much, because that was a nice scenario where we could complete the circle right from the start to the end. That was very good and interesting. So now for the next case, I would request Pritesh. Pritesh?
I'm there.
Yes, please.
So this was a 12-year-old child who was a known case of asthma, but they really didn't know since how long, for a pretty long time. Non-compliant treatment, frequent hospitalizations, and she currently had a cough and increased work of breathing for the last 2 days, and they were taking nebulizations at home with the increased work of breathing. So that was the background history. When we saw her in the ER, her appearance was abnormal. She was quite, agitated and drowsy at the same time. She was cyanosed, visible cyanosis was there, and significant work of breathing was there. So she was definitely in a life-threatening, unstable situation. And the airway was open but unstable because of a sensorium. She was tachypneic. She had poor efforts. That's important point to note here. Her air entry was poor. There was bilateral wheeze, and despite oxygen, her saturation was just 88%. She was tachycardic. Capillary refill also was prolonged, though the blood pressure was good. The skin was cold and clammy, and we are also able to see pulse paradoxes. Sensorium was altered. She did have abnormal motor movements. The blood sugars were normal, and she had an ashen gray and cyanosed color. So her physiological classification was respiratory failure, probably compensated shock, and she required immediate triage for level 1 resuscitation. So that was the status we saw her in.
Absolutely. So Chetan, we do see these kind of children. So Chetan, how would you identify, a child with asthma who's got into this life-threatening kind of a situation? What are your identification points, Chetan?
Yeah, so this child basically has all these features where we call them to be having life-threatening asthma. So first of it is the respiratory distress, which is very severe. Either it is very severe, or because of exhaustion, child is just not able to pull on and is getting exhausted and not having too many efforts. So that is again an imminent respiratory arrest sign. Then silent chest on auscultation. So when there is no air entry on both sides, so that again tells us that this bronchospasm is severe. The child is really working hard. And the sensorium, whether if it is a child who is drowsy or lethargic, or even some of them initially they will be agitated. So obtunded child, agitated child, one with severe respiratory distress, and those who are visibly either ashen gray colored or cyanosed, or saturations are less than say 90, 92. So these are the kids who are, we can classify them to this is life-threatening asthma. Another thing which is very important is what we see, most of these kids, they will present late in the night or early in the morning. Most of the asthmatics, they have worsening there. So you have to also anticipate at what time of the day you are seeing this patient. If somebody has got severe features and it is just in the evening or in the afternoon, so you assume that this child is going to further worsen in the night. So that also one has to have in mind.
Yes.
So thanks, Chetan, for summarizing. So this is from the BTS guidelines for childhood asthma. So all the points, as you have rightly said: silent chest, presence of cyanosis, a poor respiratory effort, hypotension, exhaustion, and altered mentation. These are all the clinical signs to tell that this patient is having life-threatening asthma. In addition, a saturations of less than 92, of course, we probably never measure a PEF in these kind of situations, but saturation of less than 92 is again an indicator that this is a life-threatening asthma.
Yes. So, Dr. Anjul, I'd like to come back to you again. So you have this child, as Dr. Pritesh was just mentioning, you have this child, he's done the best he could, and the child is on maxed out on the oxygen that the child has been giving. When would you consider respiratory support, non-invasive respiratory support, so that whatever you're doing, the management in the ER, how could it augment so that the child could get better?
Right. Yeah, I think what Pritesh has told till now, which is a very bad form of asthma, especially a child who's agitated and the silent chest. Now, we have come to a place where initially we knew that the people used to talk, don't use NIV or CPAP in a case of asthma because it's going to cause further generation of auto PEEP. But now we know that using non-invasive ventilation probably is going to decrease the work of breathing, decrease the fatigue of the child, and probably is going to prevent the child from going to a respiratory failure. It is basically done to buy time till rest of the bronchodilatory efforts is going to help over there. And also this sort of NIV is going to help in a child, because this is going to decrease the dead space ventilation, is going to improve the hypoxia and probably improve or splint the diaphragm, which is going to help. And also is going to decrease auto PEEP there. Yeah.
Sure. So Pritesh, so how would you choose your patients, when you would want to have NIV as your mode of support? How would you want to choose that?
So, well, when you're choosing a patient with NIV, there's certain important things that have to be kept in mind, because the interface is so bulky and it's not comfortable. You need a patient who is cooperative. You have to make sure that the patient is definitely not in respiratory failure. The settings may vary, but a rough guide is, you use it in patients who are having some amount of respiratory distress. These cutoffs are more valid for adolescents and older children, not for all children of smaller age group. So you start off with something like a PEEP of 3 to 5, and then you adjust the inspiratory pressure according to the requirement. You want to target a prolonged expiration so that your lungs get enough time to empty out. Now, there are certain situations where you have severe hypoxia or where you have very severe hypercapnia. Probably that patients you would not select. So patient selection is very, very important when you're doing an NIV in asthma. Next slide, sir.
What about mode selection? I'd just like to stop you for a while.
So,
and I
want so there are two options. You could just use only the CPAP, or you could always also use a bi-level, this one where you give a PEEP as well as you give an IPAP. Personally, I prefer most of the times to use a bi-level because it does give inspiratory support as well, and you can be able to deliver some amount of targeted tidal volume as well. But probably it may matter from units preference to preference.
I'd like to get an opinion of both Anjul, Chetan and Parag as well, between your bi-level CPAP pressure support, non-invasive, versus your HFNC, heated humidified high flow nasal cannula. Briefly. Anjul?
Yeah, so Steve, I think in this case here, where the chest is silent, probably we require that little bit more of a tidal volume. So I think bi-level CPAP here, where we have an IPAP and EPAP, is going to help, because this is going to actually decrease the offload, the pressure on the alveoli, and probably open up the splint the alveoli so that the auto PEEP is reduced. So absolutely. I will definitely use BiPAP. Yeah.
Very, very true. I think Chetan and Parag also would agree with that opinion, isn't it? Because see, this child is really sick, and to give just HFNC, I don't think is the right sort of choice. Yes, I mean, certainly for a degree of lesser severity, yes, we would certainly prefer HFNC, but not in this scenario. Parag, would you agree with that? Parag and Chetan?
Yes.
Yeah, okay.
Totally. Bi-level CPAP is something.
Yeah. So Pritesh, so what are the indications?
So patient selection is the most important thing when you're giving an NIV, not only in asthma, other situations also, because a patient on NIV actually requires much more monitoring and much more careful observation of the clinical situation than a patient on ventilator, because the interface is pinned onto the baby's mask, face and nose and covered and all that. So your monitoring becomes very, very important in this situation. And that's why selection of the right patient is important. Otherwise, you're bound to fail. You actually will end up doing a delayed intubation and causing more harm. So a patient who has severe hypoxia or severe hypercarbia, these two groups are someone whom I would be a bit skeptical about using NIV. Someone whose sensorium is affected in the form of either agitation or a depressed sensorium, again, probably not use NIV. There are a lot of secretions, there's vomiting happening, or the hemodynamics are unstable. Then these would be a group of patients where I would refrain from using an NIV and probably go ahead and consider intubation as the first line.
Yes. So that's where we are actually approaching. So you are in the emergency room. So how would you take this call in the ER, Dr. Pritesh?
So, well, what we would do is, or what we have done in this child also, is we would start off the initial stabilization, give off oxygen, start off the nebulizations and other things, and probably push a dose of steroid as soon as we get the IV line, draw a venous blood gas sample, and also prepare for intubation at the same time. In fact, that's what we were doing in this child, but in that short span of 5-10 minutes, this patient became unresponsive and started having bradycardia as well. So it almost became like a court situation, and we had to immediately proceed with the intubation in this child. So here in this situation, we did a ketamine sequence, but it's again the unit's preference. So we intubated this child, ventilated the child, and then shifted to the ICU. Next slide. So this was the first venous blood gas sample that we drew. I couldn't get hold of the official ABG report. The pH was 7 and the PCO2 was almost 78. So there was severe hypercarbia and significant acidosis. So I am more comfortable with pressure control. So that's how we manage on pressure control. So we kept a PEEP of 5. We gave a pressure support, the inspiratory pressure of almost close to 25. Initially, we started with 60% FiO2 and then we brought down. We kept a very prolonged expiration. We kept 1:3 in this child because you need to give a lot of time for the lungs to empty in this situation of asthma. And that's where it becomes tricky and challenging. So this was the X-ray after intubation. I mean, you can see the completely hyperinflated lung fields.
Yes.
So this was the blood gas after about an hour of intubation, where we can see the slight amount of improvement in the pH. It's 7.12 and the CO2s are around 68. The oxygenation was fairly good. So obviously we reduced the FiO2 rapidly after that.
So Dr. Anjul, see, so obviously this is a sick child here. So what would be your thought process from here onwards? In terms of, earlier we thought about, yes, we thought about non-invasive ventilation. But when you think about when do I ventilate? See, here in the situation, Pritesh had no choice. He was just planning to do that. And then he had to quickly go because he became unresponsive. So what are the points in favor?
Right. I think, if you look at the general teaching, they say that try to avoid intubation in case of severe asthma as far as possible, because it's difficult to ventilate the child. But nowadays we have got a smart ventilators where we can. So I think what very rightly pointed out by Pritesh, the contraindications of NIV, if you look at, and if you look at this child, it is ticking all those points over here. The child is having a physical exhaustion. There's an altered sensorium. And apart from that, if the child is going for a respiratory arrest or a bradypnea or irregular breathing, the PCO2 keeps on rising up in spite of using this, or there's an imminent cardiorespiratory failure or cardiac arrest. I think those are the indications for invasive ventilation. And we cannot delay intubating the child at this point. Otherwise, we are going to lose the child. Yeah.
Absolutely. I think all of us agree on that, isn't it, Pritesh?
Yeah, absolutely, sir. Absolutely.
So, yeah. So here, Pritesh?
In addition, this is from one of the journal articles where they also talk about the biochemical parameters. That's an acidosis, a pH of less than 7.2, PCO2s of more than 60-70, or if your PCO2 is continuously rising despite you giving non-invasive kind of a support, or significant hypoxia, which we spoke about. So basically, in general, all those things which are kind of contraindications for NIV become an indication for using an invasive ventilation in asthma. Next slide. So I won't go into details, but you have to be careful when you're ventilating asthma. When you intubate, be prepared for things. The bronchospasm can worsen during intubation. Suddenly you put in a tube, they do land up with hypotension because chest is already inflated so much. So there's a lot of PEEP which is there in the chest already. Risk of barotrauma. And then you're ventilating a child with asthma who is exhausted. There'll be electrolyte disturbances. You're going to use steroids, so myopathy, and then dynamic hyperinflation. That is the generation of auto PEEP, which is managed by giving very low rates and giving some amount of PEEP to give the lung time to empty out. And that's why it's difficult, and that's why you need to have deep sedation, sometimes even paralyze this patient, so that you are able to do that kind of situation.
Absolutely.
And strategy, again, not going into details, but more or less the same. But the most important thing is having a prolonged expiration. Try to limit your plateau pressures. They shouldn't cross 28-30, and permissible hypercapnia as long as the pH is maintained. So this patient was continued on ALI nebulizations, received magnesium sulfate. We started methylprednisolone in the ICU and also aminophylline in the ICU. Terbinafine is no longer available. We initially used ketamine. Ketamine has an additional bronchodilatory effect. So we used ketamine in this child, but as anticipated, it was very difficult to sedate the child. So we had to then rely on use of opioids and midazolam and sometimes even intermittent vecuronium. Child did have high-grade fever. It was a season of flu. So we looked at that angle as well. But once we started giving effective nebulizations and the drug started working, we were able to come down by day 2 to the pressure support, the pressures drastically. The oxygen per requirement came down. We were able to decrease the ventilatory rate. We also started tackling and tapering some amount of nebulizations, reduce their frequency by the day 2. Next slide, sir. And by day 3, we were able to start planning weaning of sedation. We gave a spontaneous breathing trial and the child was successfully having a SBT. And then we extubated to high flow nasal cannula. We didn't try post-extubation. Subsequently, it was a smoother recovery. We started the child on inhalers by the time child had.
What of thanks, Mir Japtaru?
Bhaskar sir, could you mute?
Bhaskar sir, sorry. Anjul, can you call Dr. Bhaskar, please?
Yeah, I'll do that. Yeah.
Yeah. Okay. Pritesh.
Yeah. So subsequently on the next day of extubation, we were able to wean off high flow as well. We stopped off aminophylline, shifted to ward, and subsequently, we had to put child on inhalers, have them on written asthma plan so the child doesn't land up with these kind of situation again.
Yeah.
So discharge on ICS and LABA combination, this child, with her age and the severity of exacerbations.
Sure. Thank you so much, Pritesh. That was beautifully, elucidated, because that's what we wanted everybody to take home, that message. So this is the last presentation we have with Dr. Chetan. He's got a very interesting case presentation, something that many of us would not have seen. So it'll be nice, it's something to do with the poisoning. Dr. Chetan, stage is yours, please.
Yeah. Yes. So this is a child, a boy, 14-year-old, who had a history of ingestion of some pesticide more than 12 hours ago. In a fit of rage, he had a quarrel with his mom. And initially, he didn't reveal this to family for 5 to 6 hours. And then when he started experiencing some burning sensation in mouth and throat, then he revealed it, was taken to local hospital, was given a lavage with normal saline and was referred. There was no history of vomiting, excessive salivation or perspiration or altered sensorium. And father went home, realized that the child had consumed paraquat 24% solution, and he thought must be around 30 ml. So this was the label. And on admission, child was fairly stable. He was alert, was breathing normally, had normal color, and his systemic examination was normal. Apart from oral mucosal erythema and ulceration over palate, general examination also was normal. So in ER, because the timing initially was not clear, activated charcoal of 1 gram per kilogram was given via the rice tube and was shifted to PSU after thorough counseling. So we are having a panel of pediatric emergencies, but this is a child who is fairly alert and all, but paraquat can be a very, very fatal poison, and all the effects, they start after for 24-48 hours, and you have to be starting the therapy early. So the child was shifted to PSU after thorough counseling.
So Parag, in the emergency room, what are in the recent past, in the last couple of years, I know that the trend has changed a decade ago to now, but what are the common poisonings that you keep encountering, Parag?
Yeah, so as Dr. Chetan said, it's definitely age specific what we see the poisoning, but in the smaller toddler age group, what do you see? Naphthalene ball, camphors, then you have a parenteral medications, mosquito repellents. These are quite kind of a common. Then you have an access, if there is a painting work going on, thinner, ingestion of the thinner, and then you have a caustic soda or caustic pesticides which are used in the home, cleaners. This is common. And once the age goes up, then probably a intentional one where you see a particular medication has been taken. Like in this case, it was intentional. And recently, when we had a 15-year-old boy completely unconscious and he denied everything, and then we sent an alcohol level, it was very high. So it is just a day before 15 years old, just before Holi. So it was an alcohol intoxication. So these are the things commonly we see. But as said, naphthalene, camphor, caustic things at the home, and mosquito repellents are quite common.
Yeah. So Chetan, could you just summarize them for us, please?
Yeah, so as Parag told, the household poisons in toddlers in the younger age group, because of their curiosity, their tendency to mimic adults, they will take all these things. So hydrocarbons, initially we used to see a lot of kerosene ingestion. Now kerosene has being used less and less because of this Ujjwala Yojana and all. So now it is more of mosquito repellents, and because of the pandemic, there is hand sanitizer is available in every home. So we had a couple of kids who just were unresponsive, and later on we found that hand sanitizer was taken up by the child. And again, cleaning acids and detergent and drugs. And agricultural wise, we have all these organophosphates and carbamates, endosulfan, organochlorines, and paraquat, and right poisons like aluminum phosphate, zinc phosphate. These are the common ones which are taken.
So what's the first?
When it comes to the first aid of a child who had consumed some sort of chemical, it is more or less common for the initial emergency management. You assess and intervene for the airway, breathing and circulation. You look for disability in terms of sensorium. And then when it comes to chemicals, you pay special attention to decontaminate, remove the soil clothes, give gastric lavage, give activated charcoal in certain conditions, and then you go on with the antidote or poison specific therapy.
So what is actually decontamination, Dr. Chetan?
Yeah, so when it comes to decontamination, first is skin decontamination. A lot of most of these pesticides and hydrocarbons, they can get absorbed from skin. So we have to just ingestion if it has occurred. Even from skin also, the child can receive, can get further. Hello, yeah, it can get further absorption of these compounds. So we have to wash all these exposed areas with plenty of water and soap, and remove clothes of if soiled with the chemical or the vomiters, and segregate in a bag. And whenever the child is, we are removing these clothes, ensure that we don't pull them over their faces and heads. We cut the clothes so that they don't inhale any of this medication. And whosoever is doing all this decontamination, they should wear appropriate PPE during decontamination, because they have danger of getting exposed to this. It is very important in cases of organophosphates and paraquat. So children may vomit on the people who are looking after them. So it's face shield, double gloves, and impermeable gowns. They are very important. When it comes to gastric decontamination, when do you do it? You do it in drug injections, in pesticides like paraquat and endosulfan, or rat poisons. And it best works when it is used in the first 1 or 2 hours of ingestion. But in certain cases where if the medicines are of sustained release or extended release preparations, or compounds having high enterohepatic circulation, you may need repeated doses. And one can still consider using charcoal in the first 12 to 24 hours for whatever benefit one can get. But one has to be very clear about where you're not going to use them. A child who is unconscious with an unprotected airway, and it is harmful if we do it in hydrocarbon or in acid-base ingestion. And there is no role in poisonings of cyanides or heavy metals like iron, lithium, or alcohol and inorganic salts and solvents like acetone. So next. So this child got shifted to PICU and was started with N-acetylcysteine infusion as we start in paracetamol poisoning. and also other antioxidants like glutathione, vitamin C, and tablet vitamin E. And the nephrologist also wanted to start him on dexamethasone, a high dose. He's a 50-kilo child. And parents were counseled regarding possible benefit of hemoperfusion, even though the child came presented almost 12 hours after the injection. And after consulting with the family, father agreed for it, and HD cath was placed, and he was started with hemoperfusion with charcoal filter for 4 hours, and 24 hours cycle was given for hemofiltration. All the baseline investigations were normal, and it was decided in the unit to accept lower saturation up to 85 to 90% on air and avoid supplemental oxygen as far as possible, so that we prevent the further oxidative stress. And this is the on-admission X-ray.
So what are the ill effects of paraquat on our organ systems?
Yeah, so paraquat is a weedicide, herbicide. It is commonly used in our country, but it is banned in many countries. And in some countries, there is license is required to use it. It is ubiquitously available in our country and has become a major source of intentional consumption in the last one decade. So it quickly gets absorbed and diffuses. The paraquat diffuses mostly to the lung cells and other cells and causes a lot of oxidative stress and lipid peroxidation, and produces intense inflammation. And that leads to, next slide please, that leads to a lot of multi-organ dysfunction, and it's kind of a dose dependent, how much you are consuming. So in India, we have 20-24% and 5% strengths available. So if you look, the fulminant poisoning can occur at 55 mg per kg, and this is like just 10 ml of 24% of solution for a 50-kilo child. So just a spoonful is enough to cause very severe damage, and it has got long-term effects as well. Next slide, please. So coming back to the child, so daily hemoperfusion was continued, and serial creatinine was rising with maximum of 3.4 on day 6. He started having oral bleeds and had a severe hematemesis on day 3, and upper GI scopy showed severe esophageal injury. And by day 4, his respiratory distress kept on increasing. So we started with NIV with low oxygen, and subsequently on day 6, child got intubated because of increasing respiratory distress. And he had esophageal and gastric bleeding, which led to drop in hemoglobin to 7, and received 2 PRBC transfusions. And in view of severe sloughing of oral mucosa and anticipated prolonged need of ventilation, he underwent tracheostomy on day 9. Next slide, please. So these are the serial X-rays. You can see that the child initially had just mild perioral infiltrates, which kept on increasing. He went into the pulmonary edema phase, and then by day 10, he was already in the alveolar fibrosis phase. So unfortunately, this child continued to need high airway pressure and was continued on sustained low efficiency dialysis. Also developed sepsis, which did improve on hiking antibiotics and flucon, and his multi-organ dysfunction kept on increasing. And family, in view of poor prognosis, was not willing for further escalation of therapies like ECMO, and he continued to have worsening, had bilateral pneumothoracis also, and succumbed on day 15 of illness. Next, please. So when it comes to
specific, because that was a beautiful summary or a sum up of something that that you've seen and managed from close quarters. Could you just summarize some of the other common poisons that you see and their antidotes as well, please?
Yeah. So when we look at the statistics, the most common poisonings which occur in this age group are organophosphates, endosulfan, paraquat, and aluminum phosphide. Aluminum phosphide, because of government regulation, it was earlier, a couple of decades ago, it was the main reason for mortality, but now it is less common. In organophosphates, we do have something like an antidote where atropine blocks the end organ effect, it blocks the nicotinic and muscarinic effects, and we need to keep using it for more than 24 hours. While palm, which can be used in organophosphates, it reactivates the acetylcholinesterase, and it works when it is used early in the disease process, and it won't work in carbamates. And endosulfan, this is a pesticide which goes into enterohepatic circulation, so you have to keep giving multiple doses of activated charcoal, and even cholestyramine also is used to reduce the absorption. And these children can have Statusepilepticus, so seizure control, avoiding noxious stimuli is very important. When it comes to paraquat, as we have discussed, if you give activated charcoal in the first hour and early hemoperfusion, whatever survival which has occurred, they have occurred mostly in the patients who received early hemoperfusion within 6 hours of, so timing is the essence in paraquat. And also nowadays, antioxidants role and high dose immunosuppression with high dose cyclophosphamide and solomedrol. This has started getting validated in small studies. And aluminum phosphide, here we can have gastric lavage with diluted potassium permanganate 1:10,000 solution, and again activated charcoal. But if you don't have any of these, you can simply use coconut oil and keep giving via RT. That will also further reduce the absorption of this poison. And because it releases phosphine gas and it causes a lot of cellular hypoxia and mitochondrial dysfunction and hypotension, circulatory support also is needed in this case, in these children. Next. So when it comes to poisoning in children, we have to recognize the symptoms of a particular poison and identify the ingested substance, its quantity, and its right time from the time the child has consumed this. It is very important in directing our therapy. And when you have a label or a container of the ingested substance, then it becomes very useful in targeting our therapy and prognosticating the child. And having a set protocol in place for rare poisons help in timely execution of interventions, because all these, as we saw in this child, they are very time sensitive. And if we don't have a plan in place, because these are the cases which we see, like for the last 2 years, we haven't seen any of them. But before that, we saw 3 in 3 months. So we have to have a set protocol. And there is a very good service of National Poison Information Center, which is run by AIIMS New Delhi, which runs 24/7 by 365 days. And this is the toll-free number I think we all should have, because they will be very patiently giving you all the instructions, what sort of poison this can be and how to go about it.
Absolutely, that's very nice, and that's the number which we all call, and I think we all had a great use from their expertise as well. Thank you so much, Chetan, for summarizing the whole thing. So what I would request now is I'd request the audience to type their questions in the chat box, and meanwhile what I'd ask is all the panelists, Dr. Anjul, Parag, and Pritesh, if you could start, Pritesh. What are the summary points, the main things, the takeaway points that you would say, 2 or 3 points, each of you, so that, it just gives that final impetus to the whole program.
You want me to start, sir?
Parag, yes, please. Parag, you have to unmute yourself.
Yes. So about shock, we have to remember that early recognition of shock is important, as Madam has said. Second thing is, you remember that there is a capacity of the fluid boluses. So early starting inotropes might be helpful. Remember, there are 2 types of shock which are really can be troublesome. One is a catecholamine resistant shock. Refractory shock is definitely bad with the 50% mortality. So try to search for that. Monitoring is an essential tool. At the same point of time, treating it with the physiology specific inotropes is very important. And cardiovascular and respiratory system go hand in hand. So it's not like that I'm just taking care of the heart and starting inotropes. You have to make it sure that simultaneously respiratory system has been taken care of. And once you are hitting the wall and everything you have tried, and you feel there is an improvement, this child can improve in the next few days if you support, then starting an extracorporeal therapies might be helpful in this kind of patients.
That's beautifully summed up, Parag. Now, Pritesh, could you just sum up in 3 to 4 lines what we have just discussed, and then I'd like to ask Anjul's opinion as well.
Yes, sir. So I want to basically give 4 home takeaways. The first thing is, please say no to home nebulizations, because even if you look at this child was receiving nebulizations at home despite having distress. So if you give nebulization at home, it leads to a ventilation perfusion mismatch, and you will end up having a more sicker child. So no to home nebulizations. The most important key to treatment of asthma, whether it's an OPD.
No to home nebulization is sick children, right?
Yeah, any child with acute exacerbation probably should not get home nebulization. They can use an MDI, but if the need for nebulization is there, it should be driven by oxygen in a hospital setting.
Yes, very true.
So the second thing is, the key to treatment is the most important medication in a child who is having an acute attack of asthma is oxygen. Early oxygen therapy is one of the most important and main step of treatment. Even the nebulization has to be driven by the oxygen and not by the compressor. Third important thing, which I do always in my practice, is early escalation of non-invasive support, especially in a child who is having significant amount of respiratory distress. Whether you use HFNC or NIV is left to your choice. So that has been conclusively proven in a lot of studies, though evidence overall for other things is not there. We definitely know for sure that compared to conventional oxygen therapy, that's your nasal prong or a face mask, your HFNC or NIV is definitely better in reducing the work of breathing and improving outcomes. So early non-invasive support, and very rarely a situation like this you end up having, where if it's required, you do have to ventilate with all the expertise, but that's very, very rare.
Thank you. Thank you so much. And Anjul, would you want to add a couple of points to what our colleagues have said?
Yeah, I think they have summarized it beautifully. Just 2 points I want to make, one for the shock and one for the asthma. The one is for shock is that remember that shock is always a dynamic state. So it keeps on changing. It's not that you have given a fluid bolus and you've gone to inotrope, the child might not require the fluid again. So constant monitoring of the child at bedside or by doing the invasive monitoring is very important, that you have to keep a watch on the dynamic changing position situation of the child. One thing. And I think the second important thing, I think asthma, Pritesh has beautifully summarized everything. Only one point I want to make is to impress on the parents that role of MDI is very important. The child, they give everything in the form of a syrup, but as soon as it comes to the inhaler, a lot of myths come. And I think as soon as they go back from the hospital, they stop their inhalers and the child lands up back again with a bad asthma. So tell them about the use of MDIs, take off their myth, take some time to talk about that. And as Pritesh said, very important not to use nebulization if the child is deteriorating on MDI. Immediately come to the hospital to show. I think that's going to make a lot of difference.
Thank you so much. That was very valuable as well. Chetan, you've got something to add apart from what our colleagues have just said?
I think it has been
fully summarized. Thank you. Thank you so much. And
very well. So
thanks, Andy.
Yeah.
Bhaskar Garu, anything else, Andy?
Excellent presentation. The moderation was so good, very informative and authoritative, and even the panelists had given their
stars. All of them are stars.
Yeah, really. They're galaxy. And this carry home message, with the concept which you had introduced in this panel discussion is commendable.
Yeah.
So my sincere thanks to our moderator, Dr. Satish, and the panelists, Dr. Chetan, Dr. Anjul, Dr. Pritesh, and Dr. Parag. Now I request our IAP Twin Cities branch treasurer, Dr. Vamshi Kandle, to present word of thanks.
Yeah.
Sincere thanks to all the participants.
Thank you, sir. Thank you, sir.
Thanks. Thanks.
Unmute, Dr. Vamshi, unmute.
Thank you. Thank you for the opportunity. And on this occasion, I would like to wish everyone happy Ugadi. On this, am I audible, sir?
Yeah.
Yes. Ugadi Subhakankshalandi. Vinabadtundi mee maatlo.
Thank you, sir. Satish sir, Ganta sir. Sir, your philanthropic activities are too good. I have seen you in a paper. I appreciate that. And I wish this is exactly like Ugadi Pachadi only, because routine care is all sweet only. But the critical care is like you have all the ingredients in this, of all the feelings, all the pancha shadruchulu. Like you have happiness, you have grief, you have anger, you have all the things. And I thank everyone for selecting, especially Symposium Bhaskar sir for initiating a chapter for critical care division under IAP. It's a very good initiative and apt time. Bhaskar sir has done a wonderful job. And along with Prasad sir, Dinesh sir, and Satish Ganta sir, you're all seniors. You have done excellent job. And actually, when the city was requiring this care was not there previously. And I met you all, three of you, when I required critical care. So I can really attach to it that how you have worked out from scratch, I should say. So it's an excellent thing that I have met Prasad sir, the chairperson of critical care, for taking his advice for setting up critical care, PICU and NICU. And I have met a couple of times Dinesh sir in treating critical cases at Rainbow Hospital and many occasions, and Satish sir. And I see the younger generation have taken a good lead. I've seen Anjul Dayal sir once or twice. We have talked regarding critical care. Chetan Mundada, Pritish Nagar, and Parag Dekate, all are very well. And we have our special guest speakers, Reddy, and the one specialist from Chennai Apollo Medical College as a speaker.
Suchitra madam.
Yes, Suchitra madam. Sorry, sir. Sorry, ma'am. So it's an excellent talk. I could relate to it, and many of my queries have been clarified. This also I think that many of them have also clarified it. I was thinking I was not related to critical care, but Prasad sir luckily said the academicians are also required in the teamwork in formulating the critical care, because we lack in the medical colleges also. We expect that critical care has to be developed on par, or at least the basics to save the life. That should be on par, and these type of continuous symposiums and CMEs will be very helpful. And thank you once again. And I want to remind something. Although the peak numbers start 120 and all, now around 30-40 attendees are there. It's not less on a Sunday morning. That way, very good topics you have covered. There is a Central Zone conference which is coming up, sir. I request every one of you to register for it, because this is a correct time. You will be registering as an early bird, if I'm right. Bhaskar sir will tell. 10th, 11th, 12th of June, we have a Central Zone conference where 5 different state people are coming together at Hyderabad. And Bhaskar sir is the chief organizing secretary. So over to you, sir, President sir, Bhaskar sir. Thank you all. Thank you for giving me opportunity. Satish sir, thank you.
Thanks, sir. Thanks, sir. Thanks.
Wonderful job.
Bhaskar sir, you have to unmute yourselves.
Dr. Karunakar sir, you had raised your hand. Would you like to say anything? Dr. Karunakar sir.
By mistake, I am Papa. Mute.
So there are 2 issues. When our treasurer announced the conference, as a treasurer, there is a meaning in that. Whatever it is, we request you all to actively participate as faculty members and as well elite people in the conference. I cordially invite you for the conference, which is going to be held on 10th, 11th, and 12th. And to our happiness, we have 5 workshops exclusively on intensive care. pediatric intensive care, then neonatal intensive care, around 5. That too, I am thankful to you for accepting my request and coming forward voluntarily. That itself speaks about the success of the upcoming Central Zone Conference. With these few words, I would like to conclude. Sir, Dr. Karnakar, sir, I think you are there.
Adi, by mistake, I understand.
Sir, I mean.
So thank you all. Thank you all. Wish you all happy Ugadi and Gudi Padwa.
Kindly support.
Thank you, sir.
Thank you.
Thank you. See you.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.